Hello dreamers. In this video, we are going to talk about basics of psychiatry. So what all topics we'll be going to cover in this video? I'll talk about important concepts of psychiatry, some important terminologies of psychiatry. We'll learn how to examine a patient with psychiatric symptoms, which is again very important. Now, I understand, psychiatry seems to be a very alien branch, right? There will be terms in psychiatry which we have not heard of before. So I'm going to give you lots of mnemonics and fun ways, to remember. Now, Shakespeare's, has said that what is there in the name. But I say in psychiatry, name is very important. So, I'll explain you, in the name itself, you will understand the concepts and you'll better remember. And we'll talk about, in the end, important classifications of psychiatry. We'll discuss the newer ones as well as the older ones. So let us begin. The term psychiatry is derived from two Greek words. Psyche means mind and itry means healing or cure. So basically, psychiatry is a branch of medicine which deals with problems of the mind. The term psychiatry was coined by a German physician with the name of Johann Christian Riehl. Right. Now, so what all we deal with, in psychiatry? We deal with disturbance of cognition. Now, cognition basically encompasses all the mental processes which are required to acquire information. Okay. So, sometimes we can, interchangeably use this with thought. So, we deal with disturbance of thoughts. We deal with disturbance of affect. Affect means feelings or emotions. So there are problems in the feeling. Sometimes person is feeling very sad, sometimes person is feeling excessively happy. So we deal with problems related with the feelings or affect. And we deal with disturbance of conation. Conation, that means behavior or action. A lot of time we see psychiatric patient with behavioral abnormalities. So we deal with problems related with one's behavior. Now, how do we approach a patient with psychiatric symptoms? So suppose you get a patient having some psychiatric symptoms. So how do we approach? Now, first thing which we do is we take a detailed history. Now, history, as we take in, any other branch like medicine or surgery, we take a detailed history. Now, in psychiatry, one should remember that history is not just taken from the patient, but informant as well. Informant's role sometimes become very important in psychiatry. Informant is any person accompanied with the patient. Many times we see patient, patient may say, no, I'm not having any problem. But once you talk to the informant, they may give you a detailed history which will tell, yes, there are a lot of problems associated with the patient. So informant role is very important. Then second is examination. Now, so again, examination we do, general physical examination like we do in other branches. We do systemic examination. But one very important examination which we do in a psychiatric patient is what is known as mental status examination, MSE, which is very important. We'll talk in detail about mental status examination in a while. Now, then third, we see investigation. Now, investigations have a very limited role in psychiatry. Now, I don't have the liberty which someone with medicine or surgery may be having. I don't have a blood test which I do will tell me that this patient is having 40% anxiety or 50% depression. No, we don't have that liberty. So investigations have a very limited role. They have a very limited role, and many a times we do investigations to rule out. So basically to rule out other abnormalities. For example, a patient had a head injury after which he developed some psychiatric symptoms. So we may do a brain scan to see which area is affected. Another example, a person has encephalitis. Okay, again I can do a TLC count or a CSF count to see what sort of infection is there. So investigations have a very limited role. Now whatever we are doing, ultimately our aim is to reach to a diagnosis. What diagnosis the patient is having, what psychiatric disorder the person is having, so that ultimately we can treat or manage the patient. This is how we approach a patient with psychiatric symptoms. Now, when we take history, as I told you, we take history from the informant. Now, informant, again we check the reliability of the informant, or how reliable the informant is. Okay, now reliability is assessed on various parameters. Like, first parameter is consistency. Whether the informant is consistent, that means, whether the information which is being given by the informant, it is same in each interview. Suppose, I talk to the informant, today, and the informant give me some history, and now, I again in another interview tomorrow, I talk to the informant and he gives me a very different history. So that means that it is inconsistent. Second is chronological. Whatever information the informant is giving, it should be in chronological order. Suppose a person is having symptoms since 6 months, so the informant should be able to tell which symptoms started and how the symptoms progressed. This is chronological. Then it should be coherent. Coherent means whatever piece of information we are getting, it should be logically connected so that we can understand whatever the informant is giving the information. Next is closeness with the patient. Now, closeness with the patient generally means length of stay with the patient. Now, suppose a 20-year-old male, he's living in the hostel with his friends, is brought to you, with the friends, and family members are also there. But family members, they live in another city. The symptoms have been present since 20 days. So which informant will be able to give you better history? Okay, it is the friends who are staying with the patient during that course of illness. Okay, so friends here would be more reliable informant than the parents who might not have been staying with the patient during the course of illness. Then next, again important, is the concern for the patient. Okay, how much concern is there for the patient now? So that means that there should be genuine concern for the patient, especially in case of medico legal cases. Now, for example, a husband brings the wife and gives certain details about the illness, but we get to know that there is a court case, there is a divorce case going on. So there may be some vested interest. Okay, so there may not be some genuine concern, may not be there. Okay, so concern for the patient is again important. And lastly, intellectual or observational ability of the informant again is very important to tell whether the informant is reliable or not. Okay, so these are important parameters of reliability. When we talk about history, as I said, we take a detailed history, as we take in any other branches. Okay, we talk about identification data, chief complaints, history of presenting illness, past history, family history, and one very important aspect, especially in psychiatry, is the personal history. Okay, the personal history again, we take in detail about any patient who comes for psychiatric assessment. Now let's talk about personal history. Now suppose, let us say, we have a patient who is 30-year-old female. Okay, that patient comes to us in that even, and the symptoms have been present since, let us say, since 6 months. In that person as well, we take a detailed personal history, which is very important in psychiatry. So what all things are included in personal history? The first is birth and developmental history. So we take, we talk about the birth and developmental history, when the person was in the womb of her mother, whether there were certain abnormalities or not. Again, all these details are very important. Sometimes we see that a person having prenatal exposure. Okay, prenatal exposure to certain infections, let us say like influenza, okay, may have a risk of developing schizophrenia in the future. Okay, or let us say if there is any complication during delivery, again it may lead to later on schizophrenia. So there are certain risk factors which may be present during this early developmental stages. Okay, then we take a detailed educational history. Okay, now let us say while taking the educational history, we get to know that the person was having certain problems in certain specific areas of learning. Okay, let us say the person was having a difficulty in reading. Okay, that again may hint us that the person may be suffering from something like specific learning disability. Okay, so basically in specific learning disability there is certain problems in specific areas of learning. Okay, then we take a detailed occupational history. When did the person started his occupation, whether the person changed his jobs, okay, how well he was at his job, all that we take in occupational history. Next is substance use. Now suppose we have a person, let us say this lady, she is suffering from depression. Okay, so main complaints are of depression. Sometimes there may be additional symptoms of use of some substance. For example, the patient is smoking or consuming alcohol, so we can include those history in the personal history. And lastly, we talk about marital and sexual history. When did the person got married, how are the marital and sexual relationships. Okay, and in female also we include here menstrual history. Okay, so these are the important aspects of personal history. Now there was a previous question which was asked, which of the following is not included in personal history? So let us try to answer this. Option A is early developmental history, sexual history, occupational history, and food preferences. So now yes, of course we can say food preferences are not included in the personal history. Let's talk about second, examination. Now, so as we discussed, examination of a psychiatric patient is known as mental status examination or MSE. Again important. This has also been asked previously. Now, what are the important aspects of MSE? The first is general appearance and behavior. So let us start with GAB or general appearance of behavior. Suppose you are sitting in the OPD and a person enters your room. So your examination has already started. Now in general appearance and behavior, first thing which we notice is the build. Now build of the patient can be divided into three. The person can have thin build, the person can be muscular, or the person may have obese build. Now suppose you have a 16-year-old female, who is appearing very thin and enters your OPD. Now, is there any psychiatric diagnosis which may come to your mind? Okay, very thin, extremely thin, young female, So again, it may tell us that she may be having anorexia nervosa. Okay. Now again, I'm not saying that just by looking at the build will make the diagnosis, but of course, diagnosis will be made when we'll take proper history and we will examine. But again, this will give me certain clues that she may be suffering from it. Okay, so this is again important. Then again, another patient, let us say a 19-year-old female comes who is obese. Again, what diagnosis she may be having? Again, she may be suffering from bulimia nervosa. These are eating disorders. Okay. Again, it is not that we will make the diagnosis just by looking at the build, but again, this will add on, this will help us, in making the diagnosis. Another important aspect in which, build can help us, like, there is an important, psychiatric disorder, schizophrenia. Okay, it's a psychotic disorder. In schizophrenia, we treat it with antipsychotic drugs. Okay, so we treat it with antipsychotic drugs, and we'll learn that some of these antipsychotic drugs may have an important side effect. Okay, they have important side effect which is weight gain. So a person who is obese already, we may not use drugs which have gaining weight as a side effect. Again, so build will also help us sometimes in the management. Okay, so first is the build. Second is the dressing, how the person is dressed. So we now see the dressing. Now dressing generally is seen with respect to the weather condition. Okay, so according to the weather, has the person dressed appropriately or not. Okay, let us say we have a patient, the temperature is very high. Okay, it is 42 degrees centigrade outside, very hot. Okay, and the person comes to your OPD wearing so many layers of clothes. Okay, there is muffler, there is jacket, so many layers of clothes. So tell me, is it appropriate dressing or inappropriate dressing? Okay, it seems to be inappropriate dressing. Okay, so you are in the OPD, you know, the AC is on, you're wearing very thin layer of cloth, and the person comes wearing so many layers. It tells us that it is inappropriate dressing. Okay, again, it may suggest that person may be suffering from some severe illness like schizophrenia. Okay, of course, just by looking at the dressing will not make the diagnosis, but again, this may give us certain clues that there may be some severe abnormality. So schizophrenia, we'll learn it's a psychotic illness, it's a severe mental illness, it's a psychotic illness. We'll talk about in detail. Okay, so this is dressing. Next aspect of GAB is grooming. Now, grooming basically means how the patient is maintaining his or her self-care, how the person is groomed. Okay, now suppose, you know, again you're sitting in the OPD and the person comes, you know, with, you know, uncombed hair, with very foul smell, very bad smell is coming from the body, as if the person has not taken bath for 10-15 days. Okay, then there is dirt on the body, on the face. So this all suggests that the person is having very poor grooming. Again, poor grooming may suggest that the person may be, so it is maybe suggesting of some severe illness like schizophrenia. Okay, so again, grooming may also give us certain clues about the illness. Now, next aspect of GAB is the motor activity. So we address the motor activity. Again, motor activity may be increased. Okay, there is a person who is not sitting, you know, is continuously moving. Okay, so motor activity may be high. Okay, as it is seen in certain disorders like mania. Okay, mania is a mood disorder in which the person has excessive energy. Okay, high energy, so the activity may be high, or it may be low in certain conditions. You know, for example, in depression, the motor activity is low. So patient, you know, patient comes to you, walks very slowly, you know, moves very slowly. Okay, so motor activity may be low. The next aspect of GAB is attitude towards the examiner. Okay, how is the attitude of the patient towards the examiner? Now, let us say there are, you know, many patients are very cooperative. Okay, they are very cooperative. You know, whatever you ask, you know, they generally help you, they give you details. Okay, so they are very cooperative. On the other hand, there are certain patients which are very uncooperative. Okay, they generally, you know, you tend to ask them questions, they generally would evade your question, will not, you know, answer your questions, or will be, you know, will just say that we don't want to talk. Okay, or they may just look here and there and will not talk to you. So there may be certain patients, you know, who may be very uncooperative towards the examiner. Again, generally we see that in neurotic illnesses, patients are cooperative. In neurosis, person is cooperative. We'll talk about what is neurosis and psychosis in a while. So in neurotic patient, they're cooperative, while patients who are, you know, having psychotic illnesses, okay, who are having psychosis, may be uncooperative towards the examiner. Okay, so these are important aspects of GAB. Second important aspect of the MSc is the speech. Now, speech again is very important. Okay, so we now try to assess the speech of the patient. The first important aspect of speech is the rate of speech. Rate of speech basically means number of words a person speaks in a minute. Okay, so generally, you know, when we talk to each other, when you talk to your friends, your family members, you talk in such a rate that the other person is able to understand. But then there are certain illnesses in which the rate of speech may vary. Okay, there are certain illnesses in which the rate of speech may be very high. Person is speaking very fast. Mani Dr. Ankit Gul, I'm a psychiatrist, I like playing cricket, I like, you know, watching movies. Patient is speaking very fast. Sometimes, you know, you have to, in fact stop the patient. You're not able to understand what the patient is speaking. So again, rate of speech may be high in certain disorders, like in some mood disorders. So in which mood disorders rate of speech may be high? In disorders like mania. In mania it is high. Then rate of speech may be very low. In certain disorders it may be very low. So patient may speak like this: my name is Dr. Ankit Goyal. So patient speaks few words in a minute, take lots of pauses. Okay, so it may be low. Again, in which disorder, again, certain disorders, certain mood disorders, it may be low. For example, in depression. Okay, it is low. Then second thing which we assess is the volume. Okay, so sometimes the patient's volume is very loud. So I'm just sitting next to the patient, but patient is speaking very, very loud. Doctor, this happened. So you'll say, I'm just sitting next to you. You can be a bit, low, but patient is very loud. Again, volume may be high in certain disorders like mania. Okay, while the volume may be low in certain conditions. Again, I'm sitting just next to the patient, but the patient is speaking very slowly. Okay, as if the person is whispering. The patient is saying like this, sir, this happened. So I'll say, I'm just sitting next to you, still I'm not able to hear. Be a bit loud. So patient's volume may be low. Again, in depression it may be low. Okay, lastly, in speech we see the coherence. Okay, coherence of speech. Coherence basically means whether the speech is understandable, whether you are able to understand what the person is speaking. Generally, when we talk to each other, we are able to understand each other. But there are times when person is speaking, you come and say, sir, I have talked to this patient for 30 minutes, but I have not understood what he is saying. Okay, such type of speech is known as incoherent speech or incoherence. Okay, for example, patient may speak like this: I am going to movie, Sunday is raining, my feet is 10 in size. So again, patient is speaking things, but you're not able to understand what the patient is speaking. Such speech is known as incoherent speech. And incoherent speech again may be seen in certain severe illnesses like schizophrenia. Okay, important. Okay, so these are important aspects of the speech. Let's talk about the next important aspect of the MSc, which is mood and affect. Now, generally, both of these terms are used, to denote the feelings or emotions of the person. So we are trying to understand the emotions of the patient. Now, so let's make a table so that it becomes easy for us to understand. Okay. Now, when we talk about mood disorder, there we will use the terms interchangeably. We'll say it is mood disorder or affective disorder. But there are important, differences in mood and affect. Let us try to understand. So, what is mood? So, mood is persistent and pervasive emotional state. What is persistent? Persistent means something which is present most of the time. Most of the time. Okay, so let us say, we have a female. She's 35-year-old female, and she says, since past 2 months, okay, whether it is morning, or whether it is afternoon, or whether it is evening, most of the time I'm feeling sad. Okay, so this sadness or this emotional state is persistent. Okay, then we also say it is pervasive. What is pervasiveness? Pervasiveness means it is present most of the places. Most of the places. So this female says, sir, whether I'm at my office, whether I'm at my home, or whether I'm in a kitty party, or whether I'm watching a movie in a cinema hall, I'm feeling sad. So this sadness or this emotional state is persistent. That means it is present most of the places. So this is how we define mood. It's an emotional state which is persistent and pervasive. Now, let's talk about affect. What is affect? Affect is expression of emotions, okay, or something which is observed by the therapist. Now, many times this happen, suppose any of your friend or your family member, they are sad. They've not spoken anything, but you'll go and talk to them. What happened? Why are you looking so sad? That means our emotions are also expressed on our face, in our body language, which we can observe. This is what we mean by affect. Okay, so mood is something which the patient will tell you. Affect is something which you will, as a therapist or as a doctor, you will observe. Okay, now then some other differences between mood and affect. So if I ask you, So let's try to understand mood is what? Is it an internal phenomena or an external phenomena? Mood is a internal phenomena. It is something which is internal. It is the patient who will tell you about the mood. While affect, as we can see, it is something which you will observe as a doctor. Okay, so affect is something which is external. And lastly, you should know mood is something which is long term. So basically mood is an emotional state which is present for some time. Okay, it should be present for at least some days or weeks or maybe months. Okay, so when we assess the mood, we ask the patient, how has been your mood since the past few days or weeks, okay, or maybe months. Okay, so if I have to check your mood, I will ask this, how has been your mood in the past few days or weeks. I'll not ask you how is your mood today. No, mood is a long term phenomena. Okay, while affect is something which is cross sectional. Okay, it is cross sectional. Cross sectional means at that very moment. So suppose a patient comes to me, can I tell patient's mood 10 days back? Yes, I can tell by asking the patient. But can I tell his or her mood 10 day, his or her affect 10 days back? No. For affect, you have to see at that very moment. So affect is cross sectional. So these are some important differences between mood and affect. Let us try to understand. So let us take a case. A 35-year-old female, since 2 months, she is complaining of low mood, decreased interest, decreased energy, there is less sleep and appetite. So basically she is suffering from a mood disturbance, which is depression. Okay. Now, when we talk about, when we do the MSc, so when we talk about the mood and affect, so I ask, how has been your moods in the past few days? And she says, sir, my mood is sad. Okay. Now, when I'm talking to her, during the interview, throughout the interview, I see, she appears sad. In between, she cried as well. So again, when we talk about the affect, again, affect seems to be sad or depressed. Okay. So this is how we assess the mood and affect. Now, let us say, we started treatment. And again, 2 weeks later, again, she comes. Okay. Now, when again I ask her, how has been your mood? Again, she says, my mood is sad. But when I'm talking to her, she seems to be more cheerful. She hasn't cried, and in fact, she smiled in between the interview. So when I see the address the affect, okay, it seems to be normal or euthymic. Okay, it seems to be normal or euthymic. That means there is some sort of improvement in the patient. So look, mood and affect can be different. So that is why we need to address them, assess them separately. Okay, now let us talk about some important aspects of mood and affect. The first is the quality. Okay, what is the quality? Quality basically means predominant emotional state. Okay, so whatever predominant emotional state is there, we'll say it is the quality. Okay, for example, the person may be sad, person may be cheerful, person may be euthymic. Euthymic means normal. Okay, person may be anxious. When you have to see anxious affect, suppose you're just about to give your viva, you're standing outside the room and you're with your friend, just look at each other and you will see anxious affect. Okay, that is anxious affect. Okay, then it can be irritable. Okay, irritable again, person becomes angry on small issues and sometimes even without any reason. Or person may be fearful. Okay, so there can be n number of emotional, whatever emotional state the person is having, that is the quality. Now, there may be abnormalities of the quality of affect. Okay, let us try to understand some of the abnormalities. First is elevation of mood. Okay, elevation of mood. Okay, elevation means excessive happiness. Okay, person is happy without any reason. Person may be cracking jokes, laughing without any reason. So this is elevation of mood. Again, there are various degrees of this. First is euphoria. Euphoria is basically there is increased happiness without any reason. Okay, person is again happy without any reason. Again, it can be seen in states like mania. Second is elation. Elation basically is euphoria. That means there is increased happiness. Along with this, there is increased psychomotor activity. Psychomotor activity means psycho means mind. So mind activity is high, and motor, so body activity is also very high. Again, it can be seen in states like mania. Okay, so person is very happy, Person is not sitting at one place, roaming around, maybe speaking a lot. So there is increase in the psychomotor activity. Third is exaltation. Now exaltation is basically there is increased happiness, there is increased psychomotor activity, as well as there is delusion of grandiosity. Now basically delusion of grandiosity is when the person makes big false claims. Okay, big false claims the person make. So person may say I am the richest person on the planet, or the person may claim, I know the prime minister, I know the president. So such big false claims person may make. This is delusion of grandiosity. Okay, so this is exaltation. And lastly, further high, there is ecstasy. Ecstasy is a state of bliss, it's a sense of bliss. Okay, as if me and God are become one. So that state of state of bliss, sometimes people who meditate, they generally say, or they say that they achieve this state at times. So this is ecstasy. Okay, so these are various degrees of elevation of mood. Okay, then some other abnormalities of the quality is there may be depressed mood. Okay, so person is appearing very sad, patient is feeling very low. Okay, person is crying. Okay, so there is a depressed mood. Okay, again it can be seen in conditions like depression, or there may also be at times dysphoric mood. Dysphoric basically means irritable. So person becomes angry, irritated on small issues. Again it can be seen sometimes in mania. You may find irritable mood as well. Okay, so these are some abnormalities of the quality of mood and affect. Now let's talk about some abnormalities of affect, or you can say certain fluctuations of affect. Now again these are very important. Okay, first is flat affect. First is flat affect, also known as blunt affect. Okay, so basically flat affect or blunt affect means when the emotion is not changing. Now all of us have seen ECG. Okay, electrocardiogram. When you see ECG, you will see certain waves. Okay, you will see certain waves on ECG. How is the ECG of a dead person? Okay, when a person is dead, what is the ECG? It is flat line. Similarly, you can understand it like this. Flat affect means as if the emotions are dead. The emotions are not changing. For example, I'm talking to a patient. Okay, so I'm talking about something sad. Okay, so I'm talking to the patient and talking something sad. So let us say 1 year back, his parents died in a car accident. So I'm talking about some sad event in his life, but the patient is looking like this. There is no change in the emotions. Okay, now let us say I talk about something good in his life. 6 months back he was promoted, he also became a father. So I'm talking about some good event in his life again, but the patient is looking like this. There is no change in the emotion. This is what is known as flat affect. So you should first know what is flat affect. Even giving various stimuli, there is no changes in the emotion. So first you should know this. Second is you should also know in which condition you may find flat affect. This is again very important. You may find flat affect in conditions like schizophrenia. Very important. Okay, so this you should know. Okay, so one abnormality is flat affect. Now another important abnormality is labile affect. Labile affect. Now again you can understand it is in fact opposite of flat affect. Here there is rapid and abrupt changes in emotion. Now so here the emotions, there is rapid, so you can understand it like this. Here the emotions are changing rapidly and without any reason. So in flat affect, even if you were giving some stimuli, there was no changes in emotion. While in labile affect, without any stimuli, again there are rapid abrupt changes. For example, when I'm talking to a patient, I have not cracked any joke, the patient has not cracked any joke, nothing funny has happened around, but the patient starts laughing, and within few seconds patient starts crying and again starts laughing. So there are rapid and abrupt changes in emotion without any reason. This is what is known as labile affect. So you should know what is labile affect. Second, you should also know in which conditions it may be seen. So again you can write two important conditions. One is in mania and second is in organic mental disorders. Okay. So these are two important abnormalities. Now, affect also is assessed in various other aspects. One is appropriateness of affect. Appropriate, whether the affect is appropriate or not. So in what respect we assess this? It is with respect to the setting or the situation. So according to the setting or the situation, whether the affect is appropriate or not. Okay, so suppose a person goes person goes to someone's funeral. Okay, it's a sad place, it's a someone has died in his family, and person goes to the funeral and the person starts laughing. So again, with respect to the situation, it seems to be very inappropriate. Okay, inappropriate. Okay, so you should know again, inappropriate maybe affect may be seen in conditions like schizophrenia. Okay, schizophrenia. Another example, person goes to someone's wedding and starts crying. Okay, untilness the wedding is of his or her ex-girlfriend or boyfriend, again that then it may be justifiable. Otherwise, again, person is crying in a good, in a happy event, again it is inappropriate affect. Again, can be seen in conditions like schizophrenia. Another important aspect in which we assess the affect is congruency of affect. Congruency. Now here congruency is basically with respect to the thoughts or feelings of the person. So according to the thoughts or feeling, whether it is congruent or not. Okay, now generally your thoughts or your feelings are congruent with your affect, but sometimes there is incongruent affect. Incongruent affect. Okay, so suppose suppose the patient, I ask the patient, how has been your mood, and the patient speaks like this: sir, my mood is very sad. So person's affect is, patient is appearing, his affect is appearing very happy. Okay, person's affect is very happy. Okay, it's elated, while his thoughts or his feelings is quite the opposite, it is sad. Okay, so that means the affect is not in sync or not incongruent with the feelings or the thought. This is known as incongruent affect. This is known as incongruent affect. Again, in which condition you may find incongruency? It can be seen in certain severe illnesses like schizophrenia. Okay, now since we are discussing mood and affect, let us talk about some important terms related with these. So one is anhedonia. One term is anhedonia. What is anhedonia? What is anhedonia? Anhedonia basically is there is decreased interest. There is a decreased interest in pleasurable activities. So person says that in activities which earlier he would enjoy. Okay, like for example, this 35-year-old female who says in the past 2 months she is appearing sad. She says, sir, earlier I used to enjoy watching movies, going to kitty parties, but I doing shopping, but nowadays I don't find that pleasure in those activities. This is what is known as anhedonia. Okay, again, anhedonia may be seen in certain conditions, like first, it can be seen again in depression. It can be seen, and another important condition where it can be seen even in schizophrenia. Even in schizophrenia it may be seen. Okay, in fact, anhedonia is one of the negative symptoms. One of the negative symptoms of schizophrenia. When we talk about schizophrenia, there are positive symptoms, negative symptoms. It is one of the negative symptoms. So this is anhedonia. Another important term is alexithymia. Alexithymia basically means inability to express emotions. So person is not able to express emotions, or there is inability to understand the emotions of the other person. Okay, either the person is not able to express emotions, or they're not able to understand the emotions of the other person. Okay, now please understand, it is different from flat affect. Flat affect, there is no emotions. Here the person is not able to express or understand emotion. Okay, so this is alexithymia. Now also let's try to correlate some of the neuroanatomical aspects of mood and affect. Okay, so related with emotion, let's talk about some neuroanatomy, right? So what are the structures related with emotions? So there are two important structures. One is which is the generator of emotion, or where the emotions are generated, and one is which regulates emotions. Okay, so the generator or the generation of emotions occur in the limbic system. Okay, so limbic system is supposedly the place where the emotions are generated, and which regulates our emotions, So suppose you're watching a movie, it's a very emotional scene, you feel like crying, but maybe sometimes are able to hold on. Okay, so this is, you're able to regulate your emotion. Which area regulates your emotion? So let me ask you, let's try to think, which is the, so if I give you a hint, it's a cerebral lobe. Or which is the largest cerebral lobe? Which is that? It is the frontal lobe. Okay, frontal lobe again is very important in psychiatry. We learn about important aspects of frontal lobe as well. Okay, so frontal lobe is, one point is, it regulates emotions. Okay, so these are various structures related with emotions. Now, the next and very important aspect of the MSc is the thought. Okay, now we try to understand what abnormality are there in the thoughts of the person. Okay, now the disorders of thought are divided into four important domains. Okay, and we'll discuss each of them individually. Okay, first is flow or stream. Okay, so thoughts, all of us have thoughts which are flowing. If you just sit silently for a few seconds, you will observe there are thoughts which may come in your mind. So thoughts are flowing. Okay, so there may be abnormalities of this flow or stream of thought. Second is the content. Content means, so whatever the person is thinking, there is abnormality in that content. Okay, third is disorders of form. So form means basically structure or organization. Anything which you look around, he will have a structure or a form. Similarly, our thoughts also have an organization. When this organization is abnormal, then we say these are disorders of form. And lastly, there are disorders of possession of thought. Now normally if I ask you, the thoughts which come in your mind, whose thoughts are these? You would say, of course sir, these are my thought, I possess my thoughts, of course. But sometimes there is problem in this. So person may feel that he does not possess his thoughts, so someone else is influencing his thoughts, or he is not able to control these thoughts. Then we talk about the abnormalities of possession. So these are again very important, especially for your exams as well. So let us talk about them one by one. So first is the disorders of flow or stream. So just like a river flows, the thoughts are flowing in our mind. So there can be two types of abnormalities of flow or stream. First is abnormality related with speed or tempo, the speed with which the thoughts are flowing. Okay, so again it can be increased speed, the thoughts are flowing very fast, or they are flowing very slow. Okay, second is there can be abnormality of continuity. That means the thoughts are not continuously flowing, there is problem in the continuity. So let's talk about them one by one. Now, as we discussed in the speed, or the tempo, it can be increased or it can be decreased. So two abnormalities on each side we'll discuss. Okay, let's talk about first is the increased. Now in the increased, the first and very important abnormality is the flight of ideas. Okay, let's talk about flight of ideas. Again, as I always say, remember things from the name. As the name suggests, what is flight of ideas telling you? That means that as if the ideas are on a flight. That means they are moving very fast. Okay, so what is flight of ideas? The thoughts follow each other rapidly. So there is one thought, second, third, fourth, fifth. So thoughts are coming very rapidly. Okay, so suppose you talk to a patient, thus there is flight of ideas. So person may start speaking very fast because the thoughts are coming very rapidly. So patient may talk about things illogically, but ultimately will he able to answer your question? Because the thoughts are moving so fast, they will go here and there. The person will not answer your question. So we say in flight of ideas, the goal is not reached. Important. Okay, So the thoughts are moving very fast, they will go here and there, and ultimately the person will not come back to the answer which you've asked. Okay, now although the person is speaking very fast, he will talk illogically, but somehow we see that there is some connection in these thoughts. There is some connection between these thoughts. Okay, what kind of connection it may be? It may be either connection by chance. Okay, so by some chance factor these thoughts may be connected. For example, patient may speak like this. So patient is speaking very fast. Let me explain you slowly. So patient may speak like this: my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So if you see, these one thought is connected by other by some chance factor. Okay, so this is by chance. Okay, sometimes they may also be connected by what is known as clang association. Clang association means rhyming words. So patient may speak, may speak illogical things, but all of them are connected by some rhyme. Okay, for example, patient may speak like this: Ram is the king, birds have wing, I can sing, phone goes tring tring, the weather is spring, pring pring, bring bring, pring bring. So patient is speaking again very fast, thoughts are moving very fast, and everything is rhyming. This is known as clang association. So this is flight of ideas. The thoughts are moving, very fast, goal is not reached, and they may be connected by some chance or clang association. So first you should know how to identify flight of ideas. Second is you should know in which conditions you may find this. First and very important condition, one condition you should know, it can be seen in mania. Important. Okay, so this is again very important. It can be seen in mania. Now also, in fact this question was asked few years back in a question. Again it can be seen in other conditions also. For example, it can also be seen in conditions like schizophrenia. Okay, in schizophrenia also it may be seen. Okay, and it may be seen in organic mental disorders. Okay, even in organic mental disorders. Okay, so suppose they ask you in which of the following you will find flight of ideas: mania, schizophrenia, then organic mental disorders, or all. So answer will be all. But if you have to choose one, again it is very important, it is mania. Okay, mania. So this is about flight of ideas. Under the increased speed, second is prolixity. Second is prolixity. So prolixity, basically again the thoughts are moving fast, but the speed is less than flight of ideas, so slightly less severe than flight of ideas. So sometimes it is also known as ordered flight of ideas. Okay, ordered, that means there is some orderliness in flight of ideas. Okay, it is not as fast as flight of ideas. Okay, so in prolixity, since it is not very severe, so patient will speak many things because the thoughts are moving very fast, but ultimately the person will come back to the the question. So person will answer your question. So we say in prolixity the goal is reached. Okay, the goal is reached. Now where we will see prolixity again, this is again sometimes this may be asked, so you can understand like this. Flight of ideas is very high speed, it is seen in mania. Okay, so prolixity, which is slightly less severe than flight of ideas, will be seen in condition which is in something slightly less than mania, that is hypomania. Okay, hypomania. Okay, try to correlate like this and it becomes very easy to remember. Okay, so two important abnormalities we have discussed of the increased speed. Okay, now let's talk about decreased speed. Okay, in decreased speed, first is retardation. Now retardation, as the name is telling you, there is decrease in the speed. There is decrease in the speed of thinking. Okay, the thoughts are moving slowly. Okay, so there is one thought, second thought, the thoughts are moving slowly. Okay, there may be few thoughts, so patient will also speak very slowly because the thoughts are moving slowly. So again, in which condition will you find retardation of thinking, or sometimes it is also known as inhibition of thinking? It can be seen again, very important, simple, depression. Okay, in depression there may be retardation of thinking. Then second important abnormality and very interesting is circumstantiality. Circumstantiality. Now this is again very interesting. Now what is circumstantiality? Now again, what is the meaning of English meaning of circumstantial? Person is just moving around that topic. Someone being circumstantial. What is circumstantiality? Let's try to understand. The thinking proceeds slowly, of course, the speed is slow. Then, but person gives unnecessary or trivial details. This is important in trying to assess circumstantiality. Person will give some unnecessary, some trivial details which you have not asked for, which are not relevant, not important. Okay, you have not asked for, the person will still give those elaborations. Okay, but ultimately he will answer the goal, answer the question. So we say the goal is reached. Okay, the goal is reached. So for example, if the person has to go from A to B, okay, so person will give some unnecessary trivial detail, then ultimately will reach the goal or answer the question. Okay, for example, let us say you ask the patient, who is your favorite actress? Okay, you ask the patient, who is your favorite actress? So person may start like this, I like the acting of Alia Bhatt. Okay, even Kareena Kapoor Khan is also very good. Okay, I saw her recent movie. Okay, even Katrina Kaif is also very nice. I've seen all her movie. I was very upset, when I heard she got married. Okay, but my favorite actress is Deepika Padukone. My favorite actress is Deepika Padukone. So, look, you ask a simple question, who is your favorite actress? So, patient thinking is proceeding slowly. Patient may speak slowly and give some unnecessary. All this you have not asked for. Patient will give some unnecessary trivial details you have not asked for, but ultimately he has answered your question. This is circumstantiality. Again, it can be seen in certain disorders like schizophrenia. Sometimes even in anxiety you may find this, and sometimes in normal conversations also you may find sometimes some people may give such unnecessary details. This is circumstantiality. Okay, so two important abnormalities of increased speed we have discussed and two of decreased speed. So this is abnormality of speed or tempo. Next abnormality, so we have divided the flow or stream into two. Second abnormality in the speed is in the flow or stream is continuity. Okay, the thought is not, thinking is not continuous. Okay, now again, first important abnormality and the continuity is perseveration. This is again very, very important. Okay, now you can remember it like this. So you can remember what is the English meaning of perseveration? Perseveration means to repeat. Okay, so what is perseveration? You can remember with 3 P's. Okay, you can remember with 3 P's. One is P for perseveration. The thought persists beyond the point of relevance. 3 P's. Perseveration is the thought is persisting beyond the point of relevance. So one thought keeps on persisting, keeps on repeating, although it has lost the relevance. Let me give you an example. So suppose you ask a patient, what is your name? The patient says, my name is Mukesh. Correct? This is correct. Fine. Correct. Again you ask, what do you do? The patient says, my name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. So if you see, initially this thought that my name is Mukesh was correct. But now the same thought is persisting, and it is, beyond the point of relevance. Now it is irrelevant in these other questions which I have asked. But this thought is persisting. This is perseveration. So in the exam, you may be asked, similarly a question may be asked like this, or you may be asked, patient is repeating same few words again and again. This is perseveration. So you should know how to identify perseveration. Second is you should also know where it may be seen. Now, two important conditions I want you to remember. First, very important, is organic mental disorders. Organic mental disorders. Okay. And second is schizophrenia. Second is schizophrenia. Okay. So again, in these two conditions, organic mental disorders, again very important you may find, and also in schizophrenia you may find perseveration. Okay. So this is abnormality of continuity. Okay. Next is, So second abnormality under this is thought block. As the name is suggesting, there is a block in thought, sudden arrest of thought. So there is a sudden arrest of thought. There is a sudden arrest of thought. Okay, and it will leave a blank. There will be a block. So you're talking to a patient. You're talking to a patient, and suddenly there will be a block. Okay, and suddenly after that, person will begin with something entirely new thought. Some entirely new thought the person may begin with. Okay, for example, you're talking to the person. Okay, and you're talking about let us say you're talking about the politics around in the area. Okay, so suddenly you're talking about some political issues with the person, and suddenly person stops, suddenly leaving a blank. There is a block in the thinking. It may be for a few seconds, and after, so there is a block, and after that patient starts with an entirely new topic. Okay, person may say, the weather is very cold nowadays, I'm planning to buy new winter clothes and all that, and person will go to that new topic. And please understand, he'll not be able to explain. He will not be able to explain what happened during this block. Now normally sometimes we also tend to forget while we are talking, but we will come back, we'll remember what we were talking, and we may come back to the old topic. But here the person will not able to explain what happened during this block, and will just proceed to a new topic. This is thought block. Okay, so you should know what is thought block, and second, you should also know in which condition you may find this. Again, it can be seen in disorder like schizophrenia. Okay, in schizophrenia you may find thought block. Okay, so this is the second abnormality. So if you can see, just see the list. We've talked about the first topic under thought, that is flow or stream. Into two parts it has been divided. One is speed or tempo, and the other is continuity, and we had discussed two important abnormalities of each. Sometimes they just ask that flight of ideas is a disorder of. Okay, so it's a simple question may be asked. Okay, now so next important abnormality of the thought is the content. Okay, so there is abnormality in the content. one very important abnormality under content which should definitely know is delusion. Okay, so delusion is very important in psychiatry. If you don't know delusion, we'll say not read psychiatry well. So delusion is very important. It is also described as one of the psychotic symptom. It is described as a psychotic symptom. We'll talk about this. Okay, so it can be seen in psychotic disorders and various other conditions as well. We'll talk about this. Okay, so what is delusion? Delusion is a false, fixed, unshakable idea or belief. So it's a belief or an idea which is first of all is false. It is not true. Okay, but it is fixed. The person is fixed on that thought. You try to change his thought, you try to give him evidences, that thought is unshakable. It will not change. Okay, so for example, we have, there is a 20-year-old male who is brought by the family members to you, and the family member says, sir, he's continuously saying that the neighbors, they want to kill him. Okay, he's continuously telling that the neighbor wants to kill me. Okay, so family member says, sir, it is not true, the neighbors have not have any such intention. But he is fixed on this thought. He is fixed on this thought. Family member says, sir, in fact we call the neighbors as well. So neighbors cannot even kill a mosquito, how will they kill him? The neighbors also came, they tried to convince, but he is not getting convinced. This thought is held with extraordinary conviction. He says, no, the neighbor wants to kill me. So father says, sir, he's so convinced that yesterday he got a revolver, and he says that if neighbor comes to kill me, I'll shoot him first. So he's this thought is totally fixed in his mind. This is what is a delusion. Okay, this is what is a delusion. Now also you should remember, sometimes we also add this line when we describe delusion, that it is unexplained. It is unexplained by the cultural, social or educational background of the person. Okay, that means this belief is not held with the people of his culture or of his social background or his educational background, because many beliefs are there which are commonly shared among a group. For example, For example, there is a belief in certain societies that if a black cat crosses your way, something bad or unfortunate will happen. Okay, and many people believe in this thought. Sometimes they will stop by till the time someone crosses by. They will not cross. It may take even half an hour. Okay, so again, this tends to be a false but fixed belief, but this is not a delusion, because it is shared by many people in the society, in the cultural background. In fact, this is a superstition. This is a superstition. Okay, so this third point especially tries to differentiate a delusion from superstition. Okay, so this is what is a delusion. Then there are certain types of delusion. Okay, there are many types of delusion. Let us discuss some very common and important types of delusions. The first type of delusion is delusion of persecution. First is delusion of persecution. In fact, it is the most common delusion out of all the delusions in psychiatric disorder. It is the most common delusion in psychiatric disorders. Okay, what is the meaning of persecution? Persecution basically means to harm or to kill. Okay, here basically patient believes that someone is planning to harm him or kill him. Okay, like the example we just discussed, this 20-year-old male who who says that my neighbor wants to kill me. This is a classical example of delusion of persecution. In fact, the mother also came to you and says, sir, when I give him food, what he says, you eat first, because he thinks that I am his mother, but I mix poison, and she starts crying. So it can involve even the family members. Sometimes patient comes and says, sir, I know even you are involved, so I'll not take any medicine which you will prescribe. Okay, so it can in fact involve any person. Okay, so this is delusion of persecution. Next is delusion of reference. Okay, so what is delusion of reference? Delusion of reference basically means patient believes that anything which is occurring is in reference to him. Okay, this is delusion of reference. So here the patient believes that someone is talking about him or spying on him. Okay, so patient is walking, and he sees two strangers who are standing very far from him. Okay, you cannot hear what they're saying, but the patient is convinced that these two strangers are talking about me. And you try to ask, how do you know? We cannot hear anything, but he is convinced. He may go to them and even grab their collar, and why are you talking about me? He's totally convinced. So this is delusion of reference. Or he may say that someone is spying on me, or he may enter your OPD and say, sir, I know there are hidden cameras, someone is spying on me. So this is delusion of reference. Okay, so again these are to delusion. Let us talk about some other types of delusion. Next is delusion of grandiosity. Delusion of grandiosity. Okay, so patient patient thinks that I am God. Patient feels that I am God. Okay, or patient believes that he has supernatural powers, or he knows famous people, or he has vast knowledge. Okay, he has vast knowledge. Okay, patient says that the prime minister calls me and asks me what should I do today. Okay, chief minister asks me and call me, ask me what should I do today. The president of United States call me and ask me what should I do. So famous people know, or I have vast knowledge, although even his neighbor may not know him. So patient makes such big claims. Okay, so you will find patient making such false big claims. Okay, false big claims. This is delusion of grandiosity. Okay, now again as I told you, delusion is a psychotic symptom. It may be seen in disorders like schizophrenia. Okay, but it can also be seen in certain other conditions, like even in mania. Even in mania you may find delusion of grandiosity. Again, mania can also have delusions. Again, so delusion of grandiosity again can be seen in mania. This is delusion of grandiosity. Next is delusion of nihilism. Okay, In delusion of nihilism, basically patient denies, so it is now the opposite. It is sometimes also known as, you should note, is also known as delusion of negation. Okay, now here the patient has become extremely negative. He is negating everything. He is negating everything. So this is, here the patient denies existence of his body. Patient says, sir, my body is a dead body. No, I am dead from inside. It's just a plank of card. Or patient may say, deny the existence of the loved ones. His brother is standing next in front of him and says, sir, even the people around me, they are all dead. Okay, they are all plank of card, they are dead people. Or he may just deny the existence of the world. This whole world is a dead world. It's all, everything is dead here. So this is delusion of nihilism or delusion of negation. Okay, again, it's a delusion. It can be seen in psychotic disorders like schizophrenia, delusional disorders, but it can again be seen in disorders like depression. Even in depression, it can be seen. Okay. Okay, earlier it was said that it is seen in severe depression, but now ICD-11 says even in moderate depression also you can find such delusions. Okay, it can be seen in depression. Now there is an interesting syndrome, with this name, Cotard syndrome. Cotard syndrome is basically, it's a term, it's a historical term which is used. It's basically a term which is used. So a patient with depression having delusion of nihilism. Okay, so this was termed as Cotard syndrome. So once there was a question, Cotard syndrome is, options were delusion of persecution, delusion of reference, delusion of grandiosity, or delusion of nihilism. The answer is, it is delusion of nihilism. Okay. Now, next, again certain important delusions, again associated, similar ones like delusion of enormity. Delusion of enormity. So what is delusion of enormity? Here the patient believes that he can produce a catastrophe by his action. Okay, that any catastrophe may occur, something big may occur by his actions. For example, a person may claims that he refuses to urinate. So he refuses to urinate, saying that it will flood the world. It will flood the world. Okay, that his urination may produce a catastrophe. This is delusion of enormity. Okay. Then next is delusion of guilt. Delusion of guilt. Here the patient is having excessive guilt up to a level of delusion. Patient is totally convinced that he's a very bad person. Let us say he says he is a sinner. He has done sins throughout his life. He's totally convinced that he has committed sins, up to level of delusion. He's convinced, although the patient has not done such sins or he's not a bad person, but he's convinced. Okay, so this is delusion of guilt. And then it may be delusion of poverty. Okay, here the patient is totally convinced that he is very poor. Okay, he is in a state of destitution. Okay, although in reality it may not be true, but he is totally convinced. Again, so these are some of the important delusions which you may find. Next is delusions related with some body symptom. Okay, or also known as, these are known as delusion of ill health or hypochondriacal delusions or somatic delusions. Okay, so these are certain delusions associated with some bodily symptoms. Okay, first is delusion of infestation. First is delusion of infestation, also known as parasitosis, or also known as Ekbom syndrome. All these names again are important. Okay, so what happens here, as the name suggests, infestation or parasitosis, here the patient reports of insects, they are crawling, insects are there under the skin. So the patient is totally convinced. Okay, he believes, please remember, it's a belief. It's a belief. He is convinced that there are insects under his skin. He's not saying that he's feeling them. If he says that here he's feeling those insects, then it will be a different entity. Here the patient is just convinced that he's sure that there are insects under his skin. Although you try to give him evidence, the patient will not get convinced. Okay, so this is delusion of infestation, parasitosis, or Ekbom syndrome. Okay, next is delusion of dysmorphophobia. Again, from the name itself, you can understand and remember. Dys means something is abnormal. Morpho means morphology. Something is abnormal in his morphology. So patient believes of some misshapeness of any body part. So patient may say that my nose is large, or my nose is small, my ears are large or ear is small, okay, my face is large or it is small. He's totally convinced that something is not in right shape in his body, although it is not true. He may go to various plastic surgeons, doctors also, and they will also try. Even if they try to convince him, he will not get convinced. Please understand, even if you do some plastic surgery, again the patient may continue to have the belief, because problem is there in the mind. Okay, so this is delusion of dysmorphophobia. There is an important differential, similar condition or an important differential diagnosis of this condition, which is body dysmorphic disorder. Okay, in body dysmorphic disorder, again you can see the name body dysmorphic. Something is dysmorphic in the body. Again, it is here, this belief is not very strong. So here it is more of a preoccupation. It's more of a preoccupation. Okay, so patient is preoccupied that something is abnormal in his body. Okay, but he's not that much convinced. So sometimes in body dysmorphic disorder, patient may get convinced for some time, or patient may say that, okay, oh, I think maybe you're right, my nose is okay. But in delusion of dysmorphophobia, patient will not be convinced. So this is how you differentiate. This is how you differentiate the two. Okay, so this is an important differential diagnosis which we'll discuss in obsessive compulsive and related disorder, body dysmorphic disorder. Next, under delusion of ill health is delusion of foul body odor or halitosis. Patient is convinced that there is some bad smell. There is some bad smell coming from him. There is some bad body odor coming from him. Again, patient is not saying that he is able to smell it. Okay, because if he is able to smell it, then it becomes something else. It is just a belief that there is some bad smell coming from his body, which may be noticeable or very less noticeable to the people around. So this is a belief. He is totally convinced. So it's a delusion. Okay, so these are three delusions under delusion of ill health. Okay, or hypochondriacal delusions. Now, next interesting delusion is de Clermont syndrome. De Clermont syndrome, or also known as erotomania, or also known as delusion of love. Love is not a delusion, but this is delusion of love. Now, what is love? No, I'm not asking about the definition, but love is something when we say that, I love that person. Okay, this is delusion of love. Here what happens is, patient believes that someone else, and which is usually this someone else is of a higher stature, higher social economic stature, is in love with the patient. Okay, so patient believes that someone else is in love with me. So let us say a 25-year-old female, she claims that Salman Khan is in love with me. Okay, she says that Salman Khan is in love with me. Then any new movie which is coming, any dance step which he does, she says it is to tell me, that he loves me. Okay, anything which he does in advertisement, it is just, hints that he loves me. Okay, although poor Salman Khan might have never met this patient, but she is convinced. So this is de Clermont syndrome, erotomania, or delusion of love. Again, all these names are very important. Sometimes they just ask question based on these terms. Okay, next is Othello's syndrome, also known as delusion of infidelity, also known as morbid jealousy. Again, what is infidelity? English meaning of infidelity? Infidelity means that the partner is having an extramarital affair, or the partner is cheating. Okay, so this is Othello syndrome, or delusion of infidelity and morbid jealousy. So here the patient believes that the partner or spouse is having an affair, or they are cheating. Okay, Now basically what is Othello? Othello basically is a Shakespeare's play which is based on that concept, so that is why they've given this term Othello syndrome. Okay, so here the person is convinced. Okay, of course, although it is not true, but the person is convinced. Okay, now again, it's a delusion. Again, it can be seen in various psychotic disorders. But one important point I want you to remember: there is an important substance. Okay, substance where we see this delusion of infidelity may be highly associated. What is that one substance? Okay, what is the substance I'm talking about? So person is consuming that substance for a long time, and gradually we've seen that these patients may develop this belief that their husband or their wife is having an affair. So this again is very, very important. It is alcohol. Again, delusion of infidelity is very closely associated with alcohol. So you may get a question, 40-year-old male, doubts that the wife is having an affair. Everyone around him is trying to convince him that there is nothing such like this, but still he is convinced. Which of the following substance he is consuming? Let us say the options are alcohol, cannabis, cocaine, and amphetamine. Again, many of the delusion may be, various delusions may be seen with these substances, but one important substance where delusion of infidelity is alcohol. So again, this is important. Okay, and please remember the names as well. Many a times question is asked on the names. Now, next important delusion is delusional misidentification syndrome. So we're going to talk about certain syndrome, so there are in fact 4 important syndrome under this category. Okay, so what is common is that there is misidentification. Okay, there is misidentification. So there is problem. So there is problem in the identity of the other person. Okay, so they are identifying the other person as wrong. Okay, so there are again 4 important. First 2 are very, very important. Okay, first is Capgras syndrome. Now what is Capgras syndrome? Capgras syndrome, basically patient believes that someone who is usually closely related to him. So who are the people closely related to you? Your parents, your siblings, and if you're married, your partners. Okay, so these are the people very closely, or your close friends. These are closely related people. So patient believes that someone usually closely related has been replaced by an exact double. Okay, so this is the belief in Capgras syndrome. Let us talk about a patient. So we had a patient. Let us say his name is Mr. Cap. Okay, Mr. Cap for Capgras. Okay, he was admitted with us. Okay, and his actual wife comes to meet him in the hospital, and he says to his wife that you look like my wife, but you are a hospital nurse, you're not my wife. Okay, he says to the wife, we know in reality she's the wife, but he says to the wife, you're not my wife, you're someone else, you're a hospital nurse who has come in front of me as my wife. So this is Capgras syndrome. If you can see here, the patient believes that close person, here in this case is the wife, has been replaced by an exact double. Okay, so please understand. So if I ask you physical appearance is same or different? Is same. He is acknowledging it. Yes, I know you look like my wife. Okay, now again one interesting cue or hint you can remember. Again, this is not given in your books, but you can remember, in such cases, if I ask you, the person is fighting or arguing with, okay, in such condition, he's arguing with a close person or with a stranger. Okay, he's fighting with the close person, like in this case he's arguing with the wife, that you're not my wife. Okay, so again this may help you to see that it is Capgras syndrome. Okay, again from the name, let me give you a trick to remember it from the name itself. Okay, so you can remember it like this. It is Capgras syndrome. So from the name you can see it is close person replaced by stranger. This is the belief. Okay, so from the name itself you can also remember. So I'll give you certain tricks to remember from the name as well. Okay, so this is Capgras syndrome. Next is Fregoli syndrome. Next is Fregoli syndrome. Now what is happening in Fregoli? It is the opposite. Here the patient believes that familiar person is imposing as a stranger. In Cabras, he was saying that some stranger was coming in front of him as a familiar person. Like in the case we have discussed, he says that nurse is coming as his wife. Okay, here it is the opposite. Familiar person, any person who is close to me, is imposing as a stranger. And sometimes they also claim that they can take multiple appearances. So again, let us bring another patient. Let us bring another patient and let's try to see. So we had a patient, Mr. F or Mr. Freg. Okay, he was walking and he meets a stranger. He meets a stranger. Let us call him S1. He's a stranger. He has never met him before. But Mr. Freg says to his stranger, to the stranger, that I know you look like a stranger, but you're not a stranger. You're my wife. What are you doing like this? In why you have come in front of me as a stranger? What are you doing here? So he starts arguing. So he believes that a familiar person, that is his wife, is coming in front of him as a stranger. Although it is not true. We know that. In reality, he is a stranger. Now, again he moves, he meets, after some time he meets another person, Mr. S2. Okay, another stranger. Again to this stranger he says, I know you're looking like a stranger, but you're not a stranger. You're my wife. What are you doing here? Let's go home. Why are you coming again and again as different strangers? So what is this phenomena? This is Fregoli syndrome. Okay, so this is Fregoli syndrome. Here the person believes that a familiar person imposes as a stranger. Like in the question, in the example, it was the wife, he assumes, is coming in front of him as stranger and can take multiple appearances. So if I ask you again, physical appearance is same or different? It is different. The person is acknowledging that you're looking like a stranger. He says to the stranger, I know you look like a stranger. Okay, again, just to remember, again a hint, a trick to remember, again he is fighting with the close person or with the stranger in the situation. He is arguing with the strangers. Again, this will give you a hint, okay, that this is Fregoli syndrome. Basically, Fregoli was a stage actor. He was a play actor, and in one play he would change into various characters. So from there they have given this name, Fregoli syndrome. Okay, so this is, these first two are very, very important. Okay, now then there are, next third under the delusional misidentification syndrome is syndrome of intermetamorphosis. So intermetamorphosis. So here the patient believes that other person, here the patient believes that the other can undergo changes in both physical and psychological identities and into an entirely different person. So patient believes that one person can undergo entire intermetamorphosis into an entirely new person and may live his life like this, a new person. So this is syndrome of intermetamorphosis. Okay, and lastly it is syndrome of subjective doubles. Again, it's a delusional belief that there is existence of physical duplicates of the self. Patient believes that there may be physical duplicates, my physical duplicates may be there who may be living in different parts of the world. Okay, so this is a delusional belief. This is syndrome of subjective doubles. Okay, so these are delusional misidentification syndrome. So these are some of the important delusions which we may encounter in the clinical practice. Now again, delusions can further be divided into bizarre delusion and non-bizarre delusion. These are delusions which we have divided into bizarre and non-bizarre delusions. So basically bizarre, as the name suggests, these are very bizarre, very abnormal, or very such, these may be impossible. So these are delusions which are scientifically impossible. Okay, so these are delusions which are scientifically impossible, or you can say these are culturally implausible. Okay, implausible means they are ununderstandable. You're not able to understand them. something which seems to be impossible, that it can not happen. Scientifically it is not possible. Okay, so such delusions we call as bizarre delusions. While non-bizarre delusions are, again, they are also delusions, but although they are false, but they are possible. Okay, for example, let us say delusion of infidelity. Delusion of infidelity, where the person believes that the partner or spouse is having an affair. Now, of course, in the case of the patient, it is not true, but someone's partner, having an affair can be possible. So these, these delusions are not that they cannot happen. Okay, so these are known as non-bizarre delusions. Many a time they ask question like, which of the following is a bizarre delusion, or which of the following is a non-bizarre delusion. So for example, an example of bizarre delusion, like, patients, believe that aliens, they've inserted a chip. So there were aliens who came from some other, galaxy. They've implanted a chip, and now they're recording his movements. Okay, so this is a example of a bizarre delusion. And we discussed non-bizarre, like delusion of infidelity. Okay, now this is an older concept. This is an older concept. In DSM-4, we'll talk about what is DSM-4, 5. Okay, it's a classification system. Now we have DSM-5. Bizarre delusions were given, high importance, high value was given. Okay, so they would say that if someone has bizarre delusions, it is, patient is suffering, is having schizophrenia. So just presence of bizarre delusion would, was given so much importance that a diagnosis of schizophrenia was made. Nowadays, no such importance is given. This importance has been removed, although these terms bizarre delusion, non-bizarre delusion may be used. So you may get questions like, which of the following is a bizarre or a non-bizarre delusion? But that importance or significance to bizarre delusion has been now removed because of lack of objectivity. There is lack of objectivity. Very difficult to say what is bizarre and what is non-bizarre. Nowadays we are living in the world of Avengers. In cinema, in movies, we are seeing so many things. People from intergalactic spaces coming. So such delusions may also develop, in the patient. So that is why, because of this lack of objectivity, we don't follow this concept, or that significance is not given. But still, you should know the concept. Okay. So this is about delusion. So we've talked about, the disorders, abnormality of content. Next important, domain of thought is form. So form basically means organization. So everything around, us, this pen, or, the table, chair, anything which is around you, has a structure, has a form. Similarly, our thinking, our thoughts also have a form. Okay, so any of our thoughts, if you notice, they will have a start, they will have a middle part, and then they will have an end. So every thought, will be organized like this. Okay, now when there is abnormality of form, we say it is formal thought disorder. So if you see in formal, formal means form, there is abnormality of form. So sometimes they ask formal thought disorder, that means they're talking about abnormalities of form, means disorganization. And very classically, such formal thought disorders we find in disorders like schizophrenia. Okay, in schizophrenia you may find formal thought disorders. Now let us talk about various abnormalities under form. Now before this, let us talk about, let me give you example of some normal thought, and then we'll compare it with, some abnormalities. So normal thought, let us say this is a normal thought, A followed by B, C, D. That means everything is logically connected in sequence, in logical connection. Now another example, let us say if you are, planning, let us say you're planning to go on a date. Okay, let us say, so what will be your thought? Okay, let us say you want to go to a coffee, so you will say that I'll book a cab, I'll reach cafe, I'll order coffee, you'll drink, you'll chit chat, then you'll pay and you'll come back. So this is a normal thought. So if you can see, it has a start, it has a middle part, and it has an end. So this is how, a normal thought is. Now based on these normal thought, let us talk about some abnormalities of the form. First is loosening of association. As the name suggests, just look at the name. There is loosening of association. The association or the organization of the thought has loosened up. Okay, so there is loosening of association. So there is a breakdown in the logical connection between the thoughts. So the thoughts which were logically connected, which were in sequence, now there is breakdown in that logical connection. So what you'll find that words you're able to understand. You will say, sir, the person is speaking words, I'm able to understand, but I'm not able to understand what does it mean. So sentences are not making any sense. It seems to be not making any sense. This is loosening of association. Okay, so the example which we have discussed, let us say if the person is having loosening of association, how the thoughts will appear. So it may appear like this: A followed by B, E, B, D. So everything is illogically connected. Or again, if you ask this patient, what will you do if you want to have a cup of coffee with your friend, the person may speak like this: I'll order, I'll come back, I will reach the cafe, I wear black shirt, drink the coffee, I'll book a cab. This is how the patient is speaking. Okay, not making any sense. What is he saying? I will order, I will come back, I will reach cafe, I'll black shirt, drink coffee and book a cab. So words you're able to understand, but you're not able to understand the meaning of the sentences. This is loosening of association. Okay, so again, where you will find loosening of association, we have discussed, it's a formal thought disorder, may be seen in schizophrenia. Okay, schizophrenia, it's a psychotic disorder. Okay, now next is derailment. Very interesting. Derailment, or also known as night's move thinking. Again, try to see the name, you will be able to understand the concept. So what is derailment? So a rail was moving on track and it got derailed. Okay, so this is derailment. That means the person was on track, his thoughts were on track, and suddenly he got derailed. Or also known as night's move thinking. How does a knight moves on a chessboard? It goes straight and then takes a turn, goes straight and then takes a sudden turn. Okay, so this is what is happening in thinking. Okay, so what happens here is the person jump off the track to move to a different topic and there is no logical association between these topics. So you're talking to a person, he's on track and suddenly he gets derailed. So if you just see the name and you will understand the concept. Okay, so let us see what this person may appear like. So let us say the person is on track A followed by B. Now rather than going to CDE on that same track, he changes track and comes to a new topic. Okay, this is what is derailment. Again, suppose again you ask, what will you do if you want to have a cup of coffee with your friend? So he may say, I'll book a cab, I will reach cafe, and rather than going on that topic, he changes the topic. The weather is very cold, I thought I should buy a muffler, and he goes to that new topic. This is what is derailment. Okay, so again, this is derailment or night's move thinking. Now while discussing the lecture itself, I'll try to answer some of your doubts which you may get later on. Okay, so if you remember, we had discussed about something known as thought block. How will you differentiate between thought block? There also there is a shift to a new topic. How will you differentiate? Please understand, there was a problem of continuity. So there was a pause, there was a blank. Okay, there was problem in continuity. Here there is no such pause. While talking only, he shifts to the new topic. That means he shifts to a new topic. This is derailment or night's move thinking. Okay, next is tangentiality. Again, very interesting. Again, you can remember from the name, tangentiality is derived from tangent. Now let's go back to your school days, when a teacher would ask you to draw a tangent to a circle. What's a tangent to a circle? Basically, it's a line which touches the circle at one point and it goes away. Does a tangent ever returns to the circle? Does a tangent ever returns to the circle? No, it goes away. It never comes back to the circle again. So what is tangentiality then? So here reply is to the question is oblique or tangential. That means the patient touches the topic and the person moves away. The person moves away. Does the patient ever return to the answer? So in tangentiality, will he ever be able to answer the question back? Will he return to that question? No. Goal is not reached. As you can see, the tangent never returns to the circle. Okay, so this is how you can correlate. Okay, now again, if you remember, there was something known as circumstantiality. We discussed circumstantiality when we were discussing flow or stream. here there where the person was giving, thoughts were moving slowly and giving unnecessary trivial details, but ultimately the person reaches the goal. So sometimes they compare circumstantiality with tangentiality. So in tangentiality, the person touches the topic and he does not return to the goal, so goal is not reached. So again, let us ask him the same question: who is your favorite actress, which we had asked there to the person. Okay, now here the patient may say, I like Indian movies. I like Indian movies, especially the songs and dances and in fact, Shahid Kapoor is my favorite actor who dances very well. I recently saw his movie Kabir Singh. Which was an adaptation of Arjun Reddy, and I also want to become an orthopedic surgeon. Okay, I also want to take orthopedic branch, and we continue that. So he has touched this topic. Okay, talked about favorite actors. You touched that topic, and he went away. Has he answered your question? Has he returned to the question? No. This is tangentiality. Okay, this is tangentiality. Next is neologism. Again, from the name itself, you can remember what is neo. Neo means new, and logos means words. Okay, so basically here there is a completely new word or phrase patient is using, whose derivation you cannot understand. Derivation cannot be understood, that how come he has derived that word. Okay, so you're talking to a person and suddenly he says a word which is in the language which is known to that person. That word does not exist, and you're not able to understand how did he derive that word. This is neologism. Okay, for example, let us say I'm talking to a patient who knows only English language. Okay, and while we are talking, he suddenly starts saying, sir, I bought a new Pratt knit yacht. So he says, sir, I bought a new Pratt knit yacht, and you say, what is this, what does this mean? I don't know. And we don't know in English language this word does not exist, but he says, I bought a new Pratt knit yacht, it's black in color, it's digital, but you're not able to understand what the word means. And then he points to his wristwatch and says, sir, I bought a new Pratt knit yacht, it's black in color. So he's used a new word again, and you cannot understand how he derived this word for a watch. Okay, so this is neologism. Okay, this is neologism. Again, neologism can be seen in disorders like schizophrenia. Okay, in schizophrenia, important. Okay, now next is incoherence or word salad. Okay, incoherence or word salad. Here basically it's incomprehensible thought. The thoughts are such that they're not making any sense at all. Okay, there is no sense is appearing from that thought. Incomprehensible. So, or word salad, everything is such mixed up, it is not making any sense. For example, patient may speak like this, I will go umbrella, black, fly, water. Again, nothing is making any sense. This is incoherence or word salad. Okay, again can be seen in conditions like schizophrenia. Next is talking past the point. Talking past the point, or also known as vorberedin. Okay, again now the patient is talking around that point. What does this mean? It means that patient reply shows that he has understood the question. And how we understand, how we get to know, by his answer. Okay, so it appears that he understood the question, but is deliberately talking about some associated topic. He is deliberately talking about some associated topic. This is talking past the point. For example, if you ask the patient what is the color of grass, the person replies it is red. Okay, now his reply red is telling you that he understood the question that you are asking color. It's not that in his part of the world where he lives the grass color is red. No, it's not like this. But it seems that he's talking about some associated, deliberately talking about some associated topic. Another question, let us say you ask what comes after Tuesday, the person says Sunday. Again, Sunday is telling you that he understood the question, but is deliberately talking about some associated topic. This is talking past the point or vorberedin. There is an interesting term associated with this, which is Ganser syndrome. So Ganser syndrome is basically, so it is a term which is basically used, someone having talking past the point, when talking past the point is seen in prisoners. In fact, initially when it was identified, this talking past the point, it was seen in prisoners. So they gave this term, Ganser syndrome. You can remember it like this: Ganser syndrome seen in gangsters. Okay, so it's a historical term in literature which is used. Okay, but you should know now it's not just limited to prisoners. Even in other people or even in other populations also it can be seen. Okay, but this Ganser syndrome was a term used when this was seen in prisoners. Okay, now next is word approximations. As the name is telling you, they are using approximate words. Okay, or this is also known as metonyms. So the person uses old words in a new or an unconventional way so that the meaning is evident. Now it's different from neologism, because in neologism you were not able to understand how this was derived. Here you will be able to understand the meaning or how it was derived. This you will be able to understand. For example, person says that I am wearing hand shoes. So this is telling you, okay, so they have derived this term for gloves. Okay, so person is using this word hand shoes for gloves. So you're able to understand that it's an unconventional way of saying, but you're able to understand the meaning is evident. Or the person says, in my time vessel the time is 2 o'clock. So again he derived this word for a watch. So the meaning is evident. So these are word approximations or metonyms. Okay, so these are some of the important disorders of form. Now last important domain of thought is possession. Okay, so again when we talk about possession basically either is loss of control, there is loss of control of of the thought, or there is loss of sense of possession of thinking. Either the person is not able to control his thoughts, or the person says that my thoughts are not under my possession. Now two important abnormalities come under this. Let's talk about them. First is obsession. Now please understand, now even in psychiatry books, in some places they've described obsession under content, but in those books they've just described thought under two, that is content and flow. Okay, but in the psychopathology, the basic psychopathology books like Fish, they describe obsession under possession of thought. Okay, so please remember, obsession is described under possession. Okay, now you can also remember it like this: obsession rhymes with possession. It's a disorder of possession of thought. Okay, now what is obsession? You can remember it with a what are the characteristics of obsession? We can remember it with the mnemonic Rosie. Okay, so what are obsessions? Obsessions are basically recurrent, these are recurrent thoughts or images or impulses. So person has some recurrent thoughts or images may occur in his mind, or impulses. Impulses are urges which occur, okay, which patient acknowledges as his own. These are patient's own. Patient says, I know these are my own thoughts. They are recurrent thoughts, but patient says these are my own thought. But to him they are senseless. He says these are irrational. These are not making any sense. These are senseless. He wants to stop them, but he's not able to. These are irresistible. These are irresistible. Okay, so although these are his own thought, but these are not under his control. He's not able to stop them or resist them. So these are the characteristics of obsession. For example, a person says, sir, I get repeated thoughts, I get recurrent thoughts that my hands are dirty. And so these thoughts occur 2 hours, 3 hours, 4 hours in a day. So they are so recurrent. Patient says, I know these are my own thoughts. He acknowledges them as his own, but he says, sir, these are senseless thoughts, because look at my hands, they're all clean, I just washed them few minutes back, but still these thoughts are occurring. I want to stop them, but these are irresistible. So this is again a classical example of obsession. Obsessions generally we see in obsessive compulsive disorder or OCD. Okay, so obsession is a disorder of possession. Next is thought alienation. thought alienation, or also known as passivity phenomena. Again, from the name you can see my thoughts are alien. The thoughts are alien. That means the thoughts are under some outside influence. Someone from outside is influencing my thoughts. Okay, now three important abnormalities are described under this. First is thought insertion. First is thought insertion. Again, as the name suggests, so what happens in thought insertion? Patient says that outside thoughts are inserted in my mind. Okay, so someone from outside are inserting thoughts. Okay, so sir, there is a thought in my mind that I should go and open the refrigerator and take a piece of cake and eat. This is a thought which has occurred in my mind. So this thought is not my thought. Someone from outside has inserted this thought in me. So this is thought insertion. Okay. Second is thought withdrawal. As the name suggests, here the patient says that the thoughts are taken away from my mind. Someone is taking away, withdrawing the thoughts from my mind. So if this is the patient says, my thoughts are being withdrawn. So a few minutes back, I was having a thought, but someone has taken away the thought. Okay, so my thoughts are getting taken away from my mind. Okay, so this is thought withdrawal. Next, or the last, is thought broadcast. Okay, so what is broadcast? Basically here the thoughts are leaving the patient. Okay, the thoughts are leaving the patient, and everyone gets to know the thoughts. Okay, the thoughts are getting broadcasted. Suppose there is a cricket match in another country, and you're able to watch it on your television set because it is getting broadcasted. Similarly, here the patient says that my thoughts are getting broadcasted outside. My thoughts are getting broadcasted outside. Everyone is able to know my thought. Okay, I enter a room full of people and everybody is able to know my thoughts. This is thought broadcast. Okay, so thought insertion, withdrawal, and broadcast under thought alienation or passivity phenomena. Again, it can be seen in disorders like schizophrenia. Okay, and in fact, when we'll talk about history of schizophrenia, we'll discuss, these are symptoms also described under Schneider's first rank symptoms, SFRS, Schneider's first rank symptoms. Okay, so this is about the disorders of thoughts. We've discussed 4 important domains of thought, right? The next heading under the MSc is perception. Okay, now what is perception? Basically, we get sensory information, through our sense organs, so you can see, you can hear, you can you can smell. Okay, so basically we get sensory information, okay, from our various sense organs. Now don't go with this drawing, understand the concept. Okay, so we can hear, we can hear things, we can see things, we can smell things, we can taste things, and there is a sense of touch. Okay, so basically we are getting sensory information from these sensory organs, from these sensory modalities, which is given a meaning in our brain. Okay, so for example, this pen which I am holding, so I am receiving information from my eyes that I am holding, this is a cylindrical white color object, I can touch it, it's hard in consistency, and my brain is telling me that I am holding a digital pen. Okay, so this is a perception. So anything around you, any object, any person around you, everything is a normal or a real perception. Let's talk about some abnormalities of these perception. Okay, now first important abnormality under this perception is illusion. Now what is an illusion? Illusion is basically a false perception of a real object. Okay, so it's a false perception. That means it is a disorder of perception. Okay, so let me give you an example. So a person was sleeping in the night, okay, and he wakes up, and the person wakes up and he says that he can see a snake under the bed. So person wakes up and he is able to see a snake under the bed. The person becomes frightened, the person shouts, family members come in and they switch on the light. When they switch on the light, the person see, oh, it was actually a rope. It was actually a rope. So this snake is a false perception of a real object. What was the real object? The real object was a rope. So this is a illusion. All of us have experienced, such illusions. Another example, person, says that, in the middle of the night, he gets up and says that there is a person standing behind the window. But then he switches on the light and then he sees, oh, it was actually the curtains which were moving. So this is another example of illusion. So illusion can also, normally also be experienced. Okay, it's a false perception of a real object, okay, or a real stimulus. Now, second is hallucination. Second is hallucination. Just like we have discussed delusion, I've said it's very important in psychiatry. Similarly, hallucination is very important in psychiatry. One should be very clear with hallucination. And hallucination, again, just like we've talked about delusion, it's a psychotic symptom. Similarly, hallucination is also a psychotic symptom. Okay, now what is a hallucination? Let's try to understand. It's a false perception. Again, it's a disorder of perception. It's a false perception, but without any real object. There is no real object or real stimulus, but still the person is having a perception. This is what is a hallucination. Now, before discussing hallucination, let us try to understand some important characteristics of a normal perception, or any normal object. So let us say your device, like your cell phone, it's a normal object. All of us maybe having your cell phone. So what are the characteristics of a normal perception? Let's understand. It is very clear. So all of us, you can see your mobile phone very clearly, in the screens very clearly. So it is very clear. Okay, now second is, if I ask you, where does this normal perception or this real object occur? So whether it is in your mind or is it in the outer external space? You will say, of course, it exists in the outer objective space. So any real object or real perception, it exists in the outer space. In the outer space means outside the body. Okay, now if I ask you, the cell phone, or any real object, is it dependent, the existence of that real object, is it dependent on your will? For example, can you just wish and make your cell phone disappear? No, you can't. Of course, you'll say, sir, I can throw the cell phone, but again, it will still be there. Okay, so you cannot just think and make it appear or disappear. Sometimes in our life we wish that we can disappear some people from our life, but of course it cannot be possible, because these are normal object, normal perception. So any normal perception is independent of our will, or we say is involuntary. So these are the important characteristics of a normal object or a normal perception, right? Now let's come back to the hallucination. So we know hallucination is a false perception without any real object. And what are the characteristics of a hallucination? Now hallucinations are very clear. They're as vivid as real. So for the person who is experiencing hallucination, it is as if it is real. It is very clear. Now it occurs in the outer objective space. Now suppose the person is hearing some voices. The person will say that these voices are coming from outside, either from the room or just outside the room, or from the above floor. So it is coming from the outer objective space, and it is independent of the will of the person. Okay, or it is involuntary. So person says it occurs on its own, I cannot control it. These are the characteristics of hallucination. So if you look, the characteristics of hallucination are characteristic of any real perception. So for the patient, these hallucination will appear as if it is real. Okay, they will experience it as real, but we know it is not real. These are false perceptions, but to the patient it will be as if it is real. So person says that he is hearing some voices which is not heard by other, but he is able to hear them clearly. It is coming from outside and it is not under his control. So this is again a classical example of hallucination. Or someone says that he can see someone standing. Others cannot see, but the person is able to see clearly. Okay, he can tell he can clearly describe, he can say the person is wearing a red, cap, a blue shirt, black pant, he can see clearly, so it is very clear to him, and again it is not under his control. So this is classically hallucination. If you've seen this movie, a classical example, in this movie the person is able to see here Mahatma Gandhi. Of course we know Mahatma Gandhi is no more with us, but he's able to see it very clearly. Okay, he's convinced that it is so clear to him, he's convinced that it is Mahatma Gandhi, and it is occurring in the outside space. Sometimes he see Mahatma Gandhi standing, sometimes walking around, and it is Mahatma Gandhi comes and goes on its own. Okay, so a classical example of hallucination. This is how, so the person is totally convinced that he is able to see Mahatma Gandhi because it has all the characteristics of a real perception, but of course it is false. Okay, now then there is another entity which is known as pseudo hallucination. Let us try to understand. So pseudo hallucination. Now pseudo hallucinations again are somewhat similar to hallucinations. Okay, so let us try to understand. So what are the common characteristics? These are clear. Okay, these are clear, and again these are occurring in the, and these are again involuntary. Okay, these are again involuntary. So again pseudo hallucination, just like hallucination, they are very clear and they're involuntary, not under the control of the person. Now before discussing where it exists, now let us try to understand. So I've told you that there is a the outside space, we call it as a outer objective space. Now let us say I ask you, let us say all of us might have been to any hilly area. Let me say that okay, let's try to have an image of the last hilly area you have been to. Okay, so in your mind you're able to have an image of any hilly area you have been to. Okay, so now then I say, okay, you spend a lot of time there, now let's come back to the lecture. So you're able to come back. So where where that image was created, where that image was created, it was created in the inner space. It was created in the inner subjective space. That is what we mean by inner space. Okay, or sometimes it is also known as the mind space. Okay, in the mind space. Okay, so that is the inner space. Now when we say hallucination, we have discussed hallucination, they occur in the outer objective space. Okay, it occurs in the outer objective space, while pseudo hallucinations, they occur in the inner subjective space. Okay, this is an important difference between hallucination and pseudo hallucination, where they exist. Okay, so basically if you ask me any example of pseudo hallucination, I'll say any example of hallucination can be an example of pseudo hallucination. So a person says he can see a person standing very clearly, it is in the just in front of him in the external space, outer space, it is hallucination. But when the person says it is inside his mind, it is very clear and it is not under his control, then we say it is pseudo hallucination. So this is again an important point you should remember. Okay, between pseudo hallucination and hallucination. Now let's talk about various types of hallucination. Okay, now again based on the modalities, okay, various modalities like hearing, seeing, smell, taste or touch. So based on various modalities, again hallucinations can be divided into 5 important types. First is auditory hallucinations. Here in auditory hallucination, patient is able to hear something. Now this can be, this hearing can be any. Okay, he can hear the the ringtone, or the bell, or clapping, or animal voice, or even the human voices. Okay, so it can be any. Okay, this is auditory hallucination. Please remember, most common hallucination, out of these hallucination, most common hallucination in psychiatric disorder is auditory hallucination. So this is the most common hallucination. We have discussed most common delusion was delusion of persecution. Now auditory hallucination again can be further divided or further classified as, first is first person auditory hallucination, or also known as thought echo. Thought echo. So what is this? Here patient hears his own thoughts, so as if his own thoughts are echoing. Now please understand, knowing your thought and hearing your thought is different. You say I know my thought, that is normal, but here the person says, so here the person says, sir, I have a thought, A thought comes in my mind. Let us say a thought comes that I should go out and watch a movie in a theater. This thought comes. Now I hear a voice which is repeating the same thought. So I am able to hear my own thought. This is first person auditory hallucination or thought echo. Okay. Now, then second is second person auditory hallucination. In second person auditory hallucination, the patient is able to hear voices which is talking to the patient. Now in English, grammar, when are you the second person? When someone is talking to you. So patient says, so this is the patient, he says he can hear a voice which is talking directly to him. The voice is directly talking. What are you doing? What is this? So directly he is able to hear some voices which is talking to him. Sometimes these voices may even command the patient to do something. The person may say that I hear voice which is telling me to do something. Okay, such type of second person auditory hallucinations are also known as command hallucination. Command hallucination. So there was a patient who jumped from the first floor, but he survived, and he was asked, why did you jump? The person said that I was continuously hearing a voice which was telling me to jump. So this is command hallucination. Okay, then there is third person auditory hallucination. Third person, again, there are two or more voices which are talking to each other, but the patient is able to hear them. In English, again, when are you the third person? When there are people who are talking, they're talking maybe about you, then you become the third person. So here the person says that I can hear 2-3 voices. Okay, so patient is able to hear 2 or more voices which are talking to each other. These voices are talking to each other and the patient is able to hear them. So this is third person auditory hallucination. Again, there are two important types of third person auditory hallucination you should remember. One is voices discussing about the patient. Okay, so patient says that he can hear these 2-3 voices which are talking and discussing about me. They're talking among themselves. Look, he's such a bad person. Yesterday he shouted on his mother. So patient is continuously hearing these voices which are discussing about him. Then another interesting example is voices giving a running commentary of his actions. So patient says, just like in any sports, you switch on any sport, let's say cricket, and there is a commentary going on. The batsman is ready, the bowler has bowled the ball, and now the batsman has hit it for a 6. Just like there is a commentary going on, similarly patient says that whatever I am doing, I am hearing a running commentary. So he gets up in the morning and he hears a voice that now he's got up from bed, now he's going to the washroom, now he's come back, now he's going towards the kitchen, now he started eating, now he's getting ready, now he's going to his office. So there is a running commentary which he is able to hear about his own action. Again, another example of third person auditory hallucination. So these are some important types of auditory hallucination. Now next is visual hallucination. As the name suggests, visual is the person is able to see certain things which is, to him it is as if real, but it is not seen by others. Okay, again, it can be like flashes of light, it can be any object like a bottle, it can be animals, or it can be even human faces or entire human figure. Okay, it could be anything which he is able to see. Now one important point about visual hallucination you should remember, again, it's a hallucination, it's a psychotic symptom you can find in disorders like schizophrenia, but visual, most common hallucinations in organic mental disorders, this is very, very important, in organic mental disorders are visual hallucination. This is very, very important. In fact, we will discuss this point again when we talk about organic mental disorders. Okay, so whenever you see visual hallucination, try to see, or in question or clinically also, try to see whether there is any organic mental disorder involved. Of course, it can be seen in other disorders like schizophrenia as well. Okay, in schizophrenia, any type of hallucination can be seen. Okay, this is visual hallucination. Right, next is olfactory hallucination. So what is olfaction? Olfaction basically is smell. Okay, so person is able to smell something. Okay, person enters the room and says that there is a very bad smell. He's able to have a very bad smell. Nobody is able to smell anything because there is no such smell, but person is able to smell it. This is olfactory hallucination. Okay, this is olfactory hallucination. And the next is gustatory hallucination. Gustatory hallucination. Gustatory hallucination, basic gustation means taste. So patient is able to experience some taste. There is nothing kept on his tongue, but patient is still able to taste something, something sour or something bitter or sweet. He is able to experience such taste. This is gustatory hallucination. Again, these hallucination, of course, they can be seen in disorders like schizophrenia. But very important you should know is olfactory hallucinations, gustatory hallucinations. When you see, you should think of, or you should see whether the person is having any temporal lobe disorders. Any temporal lobe disorders. Okay, now again please remember, in temporal lobe disorders like temporal lobe epilepsy, okay, all types of hallucinations can be seen, and very important olfactory gustatory hallucinations may be seen. So whenever olfactory or gustatory hallucinations are there, try to look whether they are talking about some temporal lobe abnormality like temporal lobe epilepsy. Of course, they can also be seen in disorders like schizophrenia. Right? Now, the last is tactile hallucination. Last is tactile hallucination. So tactile hallucination basically means sense of touch. Patient is experiencing some tactile sensations. Okay, again these tactile sensations can be superficial. These are just over over the skin. Okay, they are superficial sensations like hot, cold or tingling sensation. They can be kinesthetic sensations. They are inside the muscles or in the joint. Some sensation person is able to experience some rupture like sensation, or they can be even visceral. Person can experience certain sensation inside his internal organs, like someone is pinching the stomach or the liver. So it can be even visceral. Okay, now tactile hallucinations, again also known as formication. What is formication here? Basically patient experiences small insects are crawling under the skin. Okay, patient experience that he experiencing some sensations of insects which are crawling, and patient says please do something, make a incision, take them out. Of course there are no insect, but he's able to experience such sensation. This is known as formication. Now these are also tactile hallucinations, also sometimes are known as cocaine bugs or magnum bugs. Now why they are known as this? Because it is seen many times people who consume cocaine. So cocaine users, they complain of such bugs or insects sensation under their skin. So that is why it is known as cocaine bugs or magnum bugs. And many times you see clinically you see that there will be a lot of scratch marks. So clinically you will see a lot of scratch marks in these patients. Why these scratch marks? Because of this sensation they'll try to scratch. Okay, so physically you can find scratch marks. Again, such things have been asked in the past as well. So these are the 5 important hallucinations. Now there are also some special hallucinations. When we say special, because they are slightly different from the normal definition of hallucination. So we have described under special hallucinations. Okay, let us try to discuss some of the special hallucination. First is functional hallucinations. First is functional hallucination. What are functional hallucination? Here, now normally hallucination do not require any real stimulus, but here real stimulus in one sensory modality like it is hearing modality or visual modality or olfactory, any of the modalities. So any real object or real stimulus in one sensory modality, it produces hallucination in the same modality. So there is a real object which is involved, which is producing. Normally hallucination do not require any object, but a real object is producing a hallucination, and it is occurring in the same modality. This is known as functional hallucination. Okay, let's take an example. Okay, so a person says that whenever he hears ringtone of his mobile phone, so whenever his mobile phone rings, this is a normal object. This is a normal object or a normal perception. His cell phone is actually ringing. Everybody can listen to this ringtone. He says, whenever my phone rings, I hear voice of a man from outside. He is able to hear a voice of a man coming from outside, which others cannot hear. So this is a normal object. And in which modality it is? It is in the auditory modality. It's an auditory stimulus. It's a ringtone. It's an auditory stimulus. It is producing a hallucination. And what kind of hallucination? Auditory hallucination. So it is in the same modality. So this is an example of functional hallucination. Okay, it's an example of functional hallucination. Now, second is reflex hallucination. Second is reflex hallucination, which is also known as morbid synesthesia. This has been asked previously in an exam. Okay, so it is also known as morbid synesthesia. Now, what happens here is, again, real stimulus in one sensory modality, it produces. So again, here a real stimulus is required to produce a hallucination. It is producing hallucination in a different modality. In a different modality, this is what is a reflex hallucination. Okay, so for example, let us say a person says, whenever I hear the ringtone of my phone, again, this ringtone is it's a normal or a real perception. It's a real perception. Whenever he hears this, he sees a man walking in the room. He sees a man walking, which no one else can see. So this real perception is in which modality? It is auditory modality. It is producing a hallucination. What kind of hallucination? Visual, in a different modality. Okay, so this is a reflex hallucination. Another example, a person says, whenever I switch on, whenever I see a red light, so this is seeing, this is, visual modality. It's a real object. I hear a voice, which is not heard by others. So it is what kind of? It is a auditory hallucination. Okay, so this is again in different modality. Okay, it could be any type of hallucination. Okay, so this is reflex hallucination. Again, very important. Again, you can find this in psychotic disorders. But one very important point you should remember is, so let me write this point. Right, so it can be seen in associated with various substance hallucinogens, especially it can be seen with hallucinogens like LSD. Okay, so like hallucinogens, so these are certain substances of substance use disorder, LSD. So again, with LSD you may find reflex hallucination. Again, important point. Okay, then next is extracampine hallucination. Extracampine hallucination. So what is extracampine hallucination? Basically, it means hallucination which is occurring outside the limits of sensory field. So it is outside the sensory field, the limits of sensory field. Again, it can be various types. It can be any type of hallucination, but it is beyond the sensory limit. Now, normally when someone says that I am hearing some voices, it is generally in the normal limits of sensory field. For example, person says that I am hearing a voice coming from inside the room or just outside the room, or someone says I can see someone standing next to me. So it is in the sensory limits. But sometimes people experience these hallucinations which is outside the sensory limits. Okay, for example, the person who lives in Delhi, he says that he can hear the voice of his friend who lives in United States of America. So again, it is beyond the sensory limit. Another example, the person says that patient sees somebody standing behind him, while he is looking straight, so person says that he is looking straight, but he can see a person standing behind him. How is it possible? It is not possible. It is not in the sensory limits. So it is beyond the sensory limits. So such type of hallucinations are extracampine hallucinations. Next are autoscopy or phantom mirror image. Here basically patient experience seeing oneself outside the body. Okay, so patient experience himself outside the body and also knowing it to be oneself. Okay, this is autoscopy, that someone is able to see himself outside of the body and also knows that it is me only. Okay, so this is autoscopy. So like here the person is able to see himself outside the body and also knows that it is me. This is autoscopy or phantom mirror image. Now interesting is there is something known as negative autoscopy. There is something known as negative autoscopy. Here the person stand in front of the mirror, looks in the mirror, and the person sees no one. So look, in autoscopy he was seeing himself outside of the body. Also here he is standing in front of the mirror and he sees no one. This is negative autoscopy. Then there is something known as internal autoscopy. What is internal autoscopy? As the name suggests, patient says that he can see his own internal organs. So patient just looks, in his stomach, and says that he can see his internal organs like the liver, the stomach. So he can see that. Of course, it is not possible, but he's experiencing it as a hallucination. This is internal autoscopy. Okay. Now, next is the last, in fact, is hypnagogic hallucination and hypnopompic hallucination. Okay, again, let me give you a trick to remember from the name itself. Hypnagogic hallucinations and hypnopompic hallucination. Now these hallucinations, they occur at a specific time. Okay, again, hallucination normally can occur anytime, but these hallucinations are occurring at a specific time. Hypnagogic hallucinations, they occur while the person is going to sleep. Okay, while the person is going to sleep. So you can remember it like this. Okay, from the name itself you can remember. And hypnopompic hallucinations occur when the person is coming out of sleep. Okay. Okay, so you can, again, from the name itself you can remember. Again, it can be seen, it is one of the symptom, tetrad of symptom there is in a sleep disorder. There are 4 symptoms. It is one of the symptoms. What is the sleep disorder I'm talking about? In narcolepsy. Okay, in narcolepsy. So while the person is falling asleep, patient may experience some hallucination, that is hypnagogic hallucination, and while he is waking up he experiences some hallucination. This is hypnopompic hallucination. Okay, so these are some important special hallucinations. Now again, let's try to solve this doubt. Many times after discussing delusions and hallucination, we tend to have doubt that what is how to differentiate. So let's try to understand. So again, what is a delusion? Delusion is a false belief. It's a false belief. Person is thinking something which is not true, while hallucination is a false perception. Both of them are false, both of them are not true. Okay, but one is a false belief and one is a false perception. Okay, this is again important. So in delusion, the person says, I know this, I know this, that this is true, or I know this point, I know this thing. While in hallucination, patients say, I see, or I hear, or I smell, or I taste, or I have this sensation. Okay, now very very simply we can differentiate. We have discussed there is something known as delusion of infestation. Delusion of infestation, where the patient says that he knows that there are insects under his skin. It's a belief. He is not experiencing them. It's a belief. While there is something known as tactile hallucination. Tactile hallucination, where he can experience, okay, he can that he can have, he's experiencing sensation of insects, okay, under his skin. Okay, so this is one, is that person knows this, although it is false. He says, he claims to be true, that is a delusion, while hallucination is a false perception. So this is an important point. You should know the difference. Okay, be clear with the difference. Now, next part of the MSc is the higher mental functions. Okay, higher mental functions, or we are trying to also sometimes cognitive, or we are trying to assess the cognitive functions. Okay, cognitive higher mental functions. Let us try to see these higher mental functions. First is the orientation. First is the orientation. Orientation basically means awareness of the self or the surroundings. What is the time right now, which place you are right now, who are the person in front of you or near you. So this is orientation. You're oriented to time, place and person. So this is basically with respect to time, place and person. Okay, so this is orientation. Now generally when the person is disoriented, okay, when the person is disoriented, generally this is the sequence in which they lose orientation. First they become disoriented to time, then place, and then they become disoriented to person, and this comes back also in the reverse order. So person first becomes oriented to person, then place, and then time. So this is the sequence in which the person loses orientation and then he gains back in the reverse order, and this law is known as Ribot's law. Ribot's law. Okay, this law is known as Ribot's law. Now again you can remember this disorientation, D for disorientation, we'll talk about this. This again can be seen in disorders like organic disorder like delirium. In delirium the person is disoriented. Okay, it's an organic mental disorder. Okay, first is orientation, then next is attention. Okay, now what is attention? Attention is basically ability to attend to a specific stimulus without getting distracted. Now generally in a class, teacher just generally says pay attention. What does she trying to say? That there may be so many other noises around, but pay attention to what I am speaking. So pay attention to a specific stimulus. This is what is attention. Okay, now generally when we talk about attention, okay, and it is required, initially it is required to assess other higher functions. So attention, one should have intact attention so that we can assess the other higher functions. Okay, now generally the question generally is asked is how we assess it. Okay, what are the tests we do to assess attention? So one important test which we do to check attention is known as digit repetition or digit span test. Okay, digit repetition or digit span test. As the name is telling, that we ask the patient to repeat certain digits after us. Okay, so again it is it has two components, digit span test or repetition test. There is digit forward test and digit backward test. In digit forward test, basically what we do is we give some digits to the patient and ask the patient to repeat it in the forward manner. For example, I give these digit to 7. So patient will have to repeat it as 2, 7. If the person is able to do this, then I will increase the number of digits. So I may give 3, 8, 1. So again the patient will repeat as 3, 8, 1. Now normally we say a person is able to repeat 5 to 7 digits. 5 to 7 digits the person is able to repeat. Okay, so if the person is able to do this, then we say that the attention is intact. In digit backward test, what we do is we ask the patient to repeat the digits in the backward direction. For example, I give this digit 4, 7. So now the patient has to repeat at 7, 4. Now again I will increase the number of digits. I may say 1, 6, 4. So patient will say 4, 6, 1. So the patient has to repeat in the backward direction, and anyone normally can repeat them in 3 to 5 digits. The person can repeat in backward direction. So these are the tests which we do to check the attention, digit span test or digit repetition test. Now again the book says that digit forward test, if you have to choose one, is better out of the two. Okay, because digit backward test also involve various other mental functions. Okay, so if you just take attention, digit forward test may be a better answer. Okay, so this is attention. Now you may be asked, you may be asked a question. A psychiatry resident is asking a patient to repeat certain digits, after him in the forward or backward direction. What is he trying to check? He's trying to check the attention, right? Then next is concentration. Next is concentration. Now concentration is basically sustained attention. That means attention for a longer time. Many times, when you study, you say that I'm not able to concentrate after half an hour. Okay, so concentration basically means that if you are able to pay attention for a long time. Okay, now again, how do you check concentration? Again, the test which we do to check concentration is serial sevens subtraction test, or sometimes also known as 100 minus 7 test. So basically what we do is we ask the patient to subtract 7 out of 100, and whatever is the answer, continue subtracting 7 till the time he can do. So patient may subtract, in his mind say 93, then again he say 86, then again he say 79, then again he say 72, then again he say 65. Now if the patient is able to do this correctly up to 5 times, 5 times he is able to do this, we say his concentration is intact. His concentration is intact. So again, you may be asked this question. A psychiatry resident is asking a patient to subtract 7 out of 100 and continue doing that. What is he trying to check? He's trying to check the concentration. Okay, next is memory. Okay, now we're trying to assess the memory. Okay, now again, memory can memory can be of 3 types based on the duration. Okay, first is the immediate memory or short term memory, okay, or working memory. Okay, first is the immediate, short term, or working memory. Basically this is the memory of the past few seconds. So anything which happened in the past few seconds. So what was the topic which we had discussed just before? Yes, we have discussed concentration. If you are able to remember, that means your immediate memory is intact. Now the question generally is asked, what do we what test we do to check the immediate memory or working memory? Basically again, we don't do any specific other tests, because tests of attention and concentration are also invariably checking the immediate memory. Okay, we don't have to do any specific other test. Okay, now second is recent memory. Okay, so recent memory is basically memory of the past few minutes, hours, or days. Okay, memory of the past few minutes, hours, or days. So anything which happened in the past few minutes, hours, or days, if you're able to remember, we say your recent memory is intact. Again, it is important, what is the test which we do to check the recent memory? Now the test which we do to check the recent memory is 24-hour recall method. 24-hour recall method. Okay, so basically what we do here is we ask certain events which has happened in the past 24 hours, and we ask if the patient is able to remember it or not, and of course we correlate with the family members whether the information the patient is giving is correct or not. Very simple question which we ask in this is, we ask the patient what did he had in the last meal. Okay, so it's so suppose I ask you what did you had in the last meal, so you'll be able to tell me. That means your recent memory is intact. In fact, this question was asked once. A psychiatry resident was asking what did the patient had in the last meal. What is he checking? He's checking the recent memory. Okay, so or any other thing which happened in the past 24 hours, who came to meet you in the morning. Okay, so any such thing if you're asking, you're checking the recent memory. The last is remote memory. Remote memory. Remote memory, again, remote means something which is far. Remote memory is basically memory of the past few months or years. Okay, again we can test remote memory again by asking some personal information. Personal information, for example, what was the name of your school, okay, name of your wife, your children. Don't ask a male about his date of anniversary, he may not be able to tell you. Of course you can ask other questions. Okay, so any other personal information, again, what was your first job, so all those information if you ask, the person, that means his remote memory is intact. Or sometimes you can also ask certain historic events which the person has also experienced, like name past 2 or 3 prime ministers. Okay, anything historic event which had happened in the lifetime of the patient, again you can ask those questions as well to check the remote memory. Okay, so these are various types of memories based on the duration. Now next is intelligence. So we check the intelligence by asking general information, again based on the educational status. We can ask 5 states of the country, 5 rivers, or last 5 prime ministers of the country. So we can ask such general information, and you can also check the calculation skills by giving some mathematic calculations. Okay, addition, subtraction, multiplication, division, again those things we can check. Okay, now then next is abstract thinking. Okay, now we check the abstract thinking. So basically abstract thinking is ability to understand hidden meanings or to form concept. Many times you see some modern art, see some paintings which will be like this, some things, some modern art paintings, and someone will say that he can see this, or someone will try to interpret his in his own way. So basically abstract thinking is trying to understand hidden meanings or to form concept. Okay, normally abstract thinking is present in all of us. Okay, now how do we test abstract thinking? How do we test abstract thinking? One of the methods which we use to check abstract thinking is proverb testing. So proverb, basically they carry a hidden meaning. Okay, for example, you give a proverb like journey of 1,000 miles begin with a single step. So if I ask you this proverb, what does this mean? So what is the meaning of this proverb? So this proverb means that any big task will start with smaller steps. Okay, this is the hidden meaning. Okay, so if you're able to tell this, we say that your abstract thinking is intact. Okay, now what if a person said that, sir, this means that if I have taken one step, I have covered 1,000 miles. Does this mean this? No, that means the person is not able to understand the hidden meaning. So this is loss of abstract thinking. So this is loss of abstract thinking if the person is not able to understand the hidden meaning. Okay, loss of abstract thinking is also known as concrete thinking. Is also known as concrete thinking. Okay, you should know what is concrete thinking. That means loss of abstract thinking. And again, it can be seen in disorders like schizophrenia. Important. Okay, it can be seen in disorders like schizophrenia, right? Now then there is some other method also. So this is one test, proverb testing. There is another test known as similarity testing. Okay, we ask similarity between two objects. For example, you can ask similarity between a car and an airplane. Okay, so you can ask similarity. Now again the person can answer, the similarity can be in two ways. One is the general, one is general classification. Okay, or you can say functional similarity. Okay, one is functional similarity. Okay, so suppose the person says, so if I ask you what is the similarity between a car and an airplane, you can say, so both of them are mode of transport, which is correct. Okay, that means your abstract thinking is intact. Now sometimes this similarity is some specific similarity the person may like some anatomical similarity, some specific points of similarity the patient may say, or patient may just point out some difference. Okay, for example, the person says that both of them run on fuel. Okay, so there is some specific similarity, or the person may say that one runs on land and the other is on air. So in fact he's telling the difference. If person says like this, gives such answer, we say that the abstract thinking, there is loss of abstract thinking. Okay, so again another similarity which you can ask, you can ask similarity between an apple and an orange. So one who has intact abstract thinking will say both of them are fruits. Okay, And while if it is loss of abstract thinking, person may just give some specific similarities like both of them are round. Okay, so this is loss of abstract thinking. Okay, so these are two important tests which we do to check abstract thinking. Nowadays, all of us see memes these days, right? So if you're able to understand memes, that means your abstract thinking is intact. There is a song, that she has killer eyes, that someone has killer eyes. Okay, so so a person said, so this means that she has killer eye means that this is a normal eye, and this is the actress's eye. This is the actress's eye, that there is a gun inside, there is a pistol in the eye, and she shoots with the pistol. So that means the person is not able to understand the hidden meaning, deeper meaning, only is able to understand the superficial meaning. That is, there is loss of abstract thinking. Okay, now next part of the MSc is the judgment. Okay, next part of the MSc is the judgment. Now what is judgment? Judgment is basically making a right decision after analyzing your choices. Now in the courtroom, the judge hear all the evidences. Okay, and after hearing and analyzing the choices, the judge passes a decision. Okay, or passes a judgment. This is judgment. Or normally also in day-to-day lives also, you wake up in the morning, and you have so many options. Let me watch my favorite series on Netflix. Let me go and have a cup of coffee with my friends. And then you have, no, my exams are approaching, I should watch the video and I should study. Okay, so out of this you choose this, and you chose this decision. That means your judgment is intact. Okay, so every day-to-day life we make such decisions. Now judgment again is also various types. One is test judgment. First is test judgment. Now here in test judgment, we give a hypothetical situation. We give a hypothetical situation to the patient. Okay, and we ask the patient what he or she will do. Okay, so this is test. We give a test, or we give a hypothetical situation. Very commonly we ask this patient this fire problem. Okay, we ask this fire problem. So we ask, what will you do if the neighbor's house catches fire? So let me ask you, what will you do if your neighbor's house catches fire? Okay, so you may think, I'll call the fire brigade, I'll try to help my neighbors, I'll try to extinguish the fire. So these all answers would seems to be appropriate. One of the patients said, sir, what I will do, I will pour kerosene in the fire. Now is it appropriate is it intact judgment? No, it is this is telling us it is impaired judgment. So very important again, impaired judgment is seen in disorders, psychotic disorders like schizophrenia. So impaired judgment is seen in psychosis. Okay, in psychosis like schizophrenia. Okay. No, another question you may ask, let us say if there is a young child crying in front of your house alone, what will you do? So again we will say, we'll take him to the police, we'll take him to the child welfare, or we'll try to meet, make him meet his parents, such things. One patient said, sir, what I will do, I will kidnap the child. So again it is telling us it is impaired judgment. So this is again important. This has been asked also. You're asking a hypothetical question. This fire problem question has been asked previously. A psychiatry resident is asking a patient, what he will do if the neighbor's house catches fire. What is he checking? He's checking the test judgment. The next type of judgment is social judgment. So again, social judgment is basically the behaviors, his day-to-day social behaviors of the patient, okay, in daily events. Okay, in daily events, so if person is having some harmful behaviors, or harmful which may harm him, he's doing rash driving, okay, or he's fighting without any reasons, okay, or some acceptable behavior, okay, some unacceptable behaviors like person just removes his shirt and starts dancing in the class. Okay, so again these will tell that the social judgment is impaired. This will tell us that the social judgment is impaired. And lastly we see is the personal judgment. Again, personal judgment is how the patient is able to maintain his self care, okay, his self-care, if he's able to maintain his self-care. And again, normally when we check personal judgment, we can ask such question like, what will you do, after discharge? Okay, so patient may say, okay sir, I will start going to my job, I will try to come back to my routine. Again, it is telling us that the judgment is intact. One patient said, sir, after getting discharged, I'll buy a pistol, because if the neighbor comes to kill me, I'll shoot him first. Again, this may tell us that the personal judgment is impaired. Okay, so these are the three types of judgment. Again, very important is the test judgment. Many times this has been asked previously. Okay, now the last part of the MSc is the insight. Now, insight basically is the awareness of the illness. Okay, now generally in medicine, surgery, we don't talk about this. Suppose you're sitting in the emergency, a person comes with acute abdomen pain in abdomen. Will you ask this person, sir, are you aware that you're having pain? He will shout at you, sir, what are you asking? Of course I'm having pain. Now in other specialties like medicine, surgery, the person is aware of his illness. But in psychiatry, sometimes the person is not aware of the illness. But the family member will say, no sir, there is a lot of problem. Patient may say, sir, I think I am fine, my family members have gone crazy, you treat them. But in fact, the patient is having some problems. Okay, so this is insight, awareness of the illness. Now there are various grades of insight. Okay, so grade 1 is when there is a complete denial. Patient says, no, I'm not having any illness. Patient just denies that. This is grade 1. Okay, this is the lowest level of insight. Okay, so this is grade 1. Then there is grade 2. Grade 2, there is slight awareness of being ill, but again patient may deny it at the same time. So while you're talking, the patient may say, yes sir, I get irritable at times, but then within few minutes they say, no, I don't think I'm having any problem. No. So this is grade 2. There is slight awareness, but then the patient may deny it at the same time. Then comes grade 3. Here there is awareness of illness. Patient says yes, agrees that yes, I am having some problems. No, yes, I am having some sad mood, or I am having some anxiety issues. But then the patient attributes it to some either external factor. I am having this problem because the office environment is not good, my boss is not good, or may attribute it to some physical problem. There is a lot of pollution these days around, or may attribute to some medical trouble. I'm having some medical problems, diabetes in so many years, or may just attribute to some unknown factors. It is occurring because of some factors I don't know. That is grade 3. Okay, then comes grade 4. Grade 4 insight is also known as intellectual insight. Okay, intellectually the person is aware. Okay, what is intellectual insight? There is awareness of illness, that it is because of his own irrational feelings or emotions. Person knows this, but he does not apply the knowledge, this knowledge, to change his behavior. So for example, person knows that he's having these problems of depression, of sadness, and he's been prescribed medicines, he's been prescribed therapy, but he's not taking them regularly, not coming to therapy, not modifying his lifestyle. So this is intellectual. Intellectually he knows, but he's not applying this knowledge. Okay, so we know we should study, we intellectually we know, but we are not studying. So that is intellectual insight. Then the last or the highest level of insight is grade 4 insight, grade 5 insight, or true emotional insight. This is the highest level of insight. Here the person is aware of his illness because of irrational feelings and emotions, and now he's applying this knowledge to change his behavior. He's taking medicines properly, he's going for therapy sessions, modifying his lifestyle. So again he's applying the knowledge, okay, to change his behavior. This is the highest level of insight. Okay, so these are the important grades of insights. Okay, grade 1 is the lowest and grade 5 is the highest. Now again, when we divide the psychiatric illnesses, we divide into neurosis and psychosis. We say in neurosis the insight is present. So person is aware of his problem and he will come to you and ask, please help me. While in psychotic disorders, the insight is absent. It may be the family members who may bring the patient, but the patient says, I don't have any problem. So there is insight is absent. Okay, so these are the important headings of the MSc. Okay, now after the MSc, let us talk about various classifications in psychiatry. Okay, Now there are two important current classifications which we follow, okay, to classify any disorder. So if I have to tell you, criteria of depression, I'll say it is according to either ICD or DSM. So these are the classifications we follow. Okay, so first is the ICD 11. Now it is the latest version of ICD. Earlier it was ICD 10, but now in 2022 we have ICD 11. ICD is basically International Statistical Classification of Psychiatric Diseases. 11th is the 11th revision. It is the latest revision. And who has given ICD 11? WHO, World Health Organization. So ICD 11 is given by WHO. Then there is another classification which is DSM-5. Now ICD 11 is for all disorders, not just psychiatric but all the other disorders of medicine, surgery, dermatology, obs and gynae. So all the disorders are classified under ICD 11 in various chapters. While DSM-5 DSM is basically Diagnostic and Statistical Manual of Mental Disorders. It is only for mental disorders, and here 5 is the 5th edition. Okay, 5 is the 5th. So basically DSM-5 was a newer version when ICD 10 was there. Okay, so ICD 10 was quite old. So DSM-5, which came in 2013, so a lot of changes which were made by DSM-5 is also made by ICD 11. So ICD 11 has done similar changes which were made in DSM-5. And DSM-5 is given by APA, that is the American Psychiatric Association. But again, please remember, in India we follow generally both. When we'll talk about specific disorders, I'll tell you according to DSM or according to ICD 11. Okay, so these are the two important current classifications which we follow. Now DSM-4, TR, it had a multi-axial system. It had described the psychiatric disorder into various axes. Okay, so it has divided or made a diagnosis into various axes. Let's try to briefly discuss these axes. So there were 5 axes. So in DSM-4 TR is text revised. Okay, 5. So there is an axial classification, multi-axial classification. So 5 axes are there. You can remember it with the help of the digits of your hand. Okay, I'll tell you a trick to remember. Axis 1 you can correlate with the thumb. Thumb, which is one of the important digits. So here in axis 1, all the psychiatric disorders, psychiatric diagnoses are put under axis 1. Okay, then axis 2 or the index, you can correlate with the index finger. Generally index finger we use to point it to other. You are like this, you are like this. So index 2, basically here we write the personality disorders or mental retardation. Okay, personality disorders, let me write it on in mental retardation. Okay, now then axis 3, or you can with the middle finger, it is the largest finger. So basically here in axis 3 we have all the other general medical conditions, all the general medical conditions if the person is having, we describe it under axis 3. Now axis 4, you can remember it, so it's a ring finger. When someone gets married, they put a ring in this finger. So it is basically, you can remember, psychosocial or psychosocial or environmental problems are described under axis 4. And axis 5 with the little finger, generally if you have to attend the nature's call, you point to this finger, this is. So basically axis 5, you can say this is basically functioning of the person. How is the functioning? So this is global assessment of functioning. How is the functioning of the patient? Okay, so basically it is described from 0 to 100, 0 being the minimum functioning and 100 being the highest functioning. So we describe, so let us say someone has a functioning of 40. Okay, so we have a scale, so based on this we can describe the functioning. Okay, so these are the 5 axes in which we describe under DSM-4. Okay, so for example, let me give you just a small example. Let us say someone has, you know, schizophrenia. So in axis 1 we'll write schizophrenia. In axis 1 we'll write schizophrenia. Let us say the person has a personality disorder. There is something known as schizotypal personality disorder. So that I will put under axis 2. Okay, and let us say this patient also has diabetes mellitus. Okay, so that I will place it under axis 3. Now this person is also undergoing, you know, he just underwent, you know, separation or divorce from his wife. So again there are psychosocial problems are there. So let us say I'll put it under the divorce, I'll put it under axis 4. And you know, when I see the functioning, I see the functioning of the person is around 40. There is decrease in the functioning. So this is how the axial system was used. Okay, so this is the multi-exit classification of DSM-4TR, right? Now those were the, you know, newer classification, DSM and ICD. Now psychiatric disorders, you know, previously in older days we would divide the class, you know, psychiatric disorders into organic disorders and functional disorders. Now these are, you know, again these are older terms, but again you should know, many a times, you know, we use these, you know, terms, and you should know the concept. Okay, now basically organic disorders generally we use to describe any disorders which would have a demonstrable, they would have a demonstrable or a apparent cause. There was an apparent cause. Okay, so any disorder, you know, which had psychiatric symptoms and there was a demonstrable or an apparent cause was there, those we used to call it as organic disorders. For example, let us say someone had a head injury, you know, and after which person developed some psychiatric symptoms. So you can see the head injury, and maybe, you know, if you do a scan, a CT scan or an MRI, you'll see, you know, some lesions. So you're able to demonstrate a cause. Or let us say someone has encephalitis, okay, you do examination, you'll see certain signs, you do a TLC or CSF count, you'll see infection. So you're able to see. Or let us say someone has hypo, you know, natremia, low sodium. Again, patient may develop some psychiatric symptom. You see, you check the sodium levels, it will be low. So these are demonstrable cause. So those were classified as organic disorders. Rest all the psychiatric disorders which would not have, there was no demonstrable or no apparent cause, those were classified as functional disorders. Okay, for example, you know, normally, you know, if you do a brain scan of a patient of depression or a blood count, generally you may find absolutely, you know, normal findings. Okay, but of course now our understanding has improved. Now we know even, you know, disorders like depression, schizophrenia, they also have some causes. You know, there are problems in neurotransmitters, subtle problems in certain areas of the brain also. So now we know nothing is functional. But this is an older way of classifying. Okay, this is an older way of classifying. And functional disorders we would further classify as neurosis and psychosis. Okay, so functional, they further were classified into neurotic illnesses and psychotic illnesses. Again, let us try to understand some important differences between neurosis and psychosis again. But please understand, these classifications are not very crystal clear, because, you know, there are better ways of classifying, but still you should know. So let us talk about neurosis and psychosis. Now again, many of these points we've already discussed. So insight, if I ask you, insight in neurosis is present while it is absent in psychosis. Now personality, when we say, you know, personality basically is a unique, you know, way of dealing with day-to-day situations. So all of us, you know, we say generally personality develops by the age of 18 years. All of us have a personality. Okay, and the personality, as I described, it is a way with which person deals with day-to-day situation. For example, you know, you may have some friends, you know, whatever exam it may be, even if they've revised well, you know, they'll say, oh my god, I have an exam tomorrow. They'll be worried. And some of us, you know, some of you, you know, you'll see that any exam, you know, they will, you know, even before the exam, they'll be very chilled. Oh, it's just an exam. So this is their, you know, personality. Okay, so we say someone who develops neurotic illness, his personality is preserved. Personality is preserved. That means personality is not affected. It remains the same. While someone who develops psychotic illnesses, we say their personality are affected. Personality may be changed. So the family members may notice that now he is not the same person as he used to be. So personality is affected. Now, reality testing is basically the touch with reality, or you're able to differentiate what is real and what is unreal. In neurosis, we say reality testing is present. It is intact. Person is able to differentiate what is real and what is unreal. While in psychotic disorders, person may be talking to someone although no one is there. Person is not able to differentiate between reality, real and fantasy. Okay, so he's not able to differentiate between what is real and what is unreal. So reality testing is absent or impaired. Judgment we have already discussed. Judgment we have discussed, like the fire problem we discussed. Judgment is intact in neurosis while it is impaired in psychosis. Okay, as I told you, fire problem, a patient with psychosis may say I'll pour kerosene. Okay, now this is again important. We have discussed delusions and hallucination. So we know what is delusion and what is hallucination now. So tell me, delusion and hallucination are absent. This is very important. Absent in neurosis while they are present in psychosis. Again, very important. Okay. Now, some examples of examples of neurotic illnesses like anxiety disorders. Okay, like anxiety disorders, like panic disorder, generalized anxiety disorder, phobias. These are neurotic illnesses. Then even OCD, OCD is there. Okay, then other disorders like sexual disorders. Okay, eating disorders. Okay, all these again these are neurotic illnesses. Okay, and even like depression, right? Now, some of the examples of psychosis. One very important example, we've been discussing this for so many times: schizophrenia. Schizophrenia. Even delusional disorders. Delusional disorder. Okay. Mania. Okay. Now, even but we have discussed sometimes a patient with depression also can develop sometimes delusions or hallucinations. They can develop delusions like delusion of nihilism we have discussed. In fact, any type of delusion may occur. So that is known as psychotic depression. So please try to understand that this classification is not very crystal clear. Some from here characteristic may go to that side and vice versa. So that is why I said it's an older way of classifying, but still you should know, okay, what is neurosis and what is psychosis. Okay. Now, now lastly, whenever in psychiatry, we use this term disorder. What do we mean by this? Now, this is again very important and very interesting concept we should understand. Like for example, suppose your exam didn't go well, or someone did not do well in the interview. The person is, let us say, sad for a few days and then becomes all right and starts doing all the normal things normally. So how to say whether it is depression or it was normal fluctuations of the mood? Okay, so whenever we use this term disorder, that means that means that he fulfills the symptom criteria. So let us say when we'll talk about depression, I'll tell you that there are certain criteria and these are the number of symptoms should be present in a patient when we call the person is having depression. Then it should also fulfill the duration criteria. Like for example, in depression we say the symptoms should be present for at least 2 weeks, at least 14 days or more. Then we say someone is having depression. Now these two are very, very simple, important and very simple to understand. Thirdly, please understand, whenever we talk about any disorder in psychiatry, that means that there is impairment of functioning at certain level. At some level there is impairment of functioning. Impairment of functioning means the patient's occupational activity, okay, or patient social activity, okay, or patient's personal activities or self-care, like or personal activities or self-care, they are affected. Okay, like again they if the symptoms, like if the depression is mild, The person may go to his office but may not be able to do work properly. His social activities may decrease. His personal activities, self-care may also decrease. And if it is very severe, they may be even more disrupted, like he stops going to the work, stops meeting people, stops taking self-care and personal activities. Okay, so it may vary, degree may vary, but some level of impairment you will find. Okay, and many a times in certain disorders it may be high, and in some disorders it may be low. Okay, like for example in schizophrenia, when we talk about schizophrenia, it's a psychotic disorder. There is, impairment of functioning, you will see, quite evidently you will see. But then there is another psychotic disorder, that is delusional disorder. Delusional disorder, we will discuss that this functioning will be, very less impairment will be there, very limited impairment will be there. But again, any disorder, when we call it as disorder, that means there is some level of impairment. Okay, so again, this is important point, an important concept. Okay, now let's talk about some questions. Since we have discussed this, let's try to understand the concept in the form of some questions. So a patient says, very interesting question, says home is sweet, sweet in diabetes, diabetes, urine has smell, smell is hell. What is the symptom? So patient is speaking these things. Now let us try to understand, is it derailment? What was derailment? Derailment we have discussed under thought, and under thought we have discussed it under the form. The patient, jump off the track. Patient is on track and is jump off the track. Now this is not telling us whether he was on track or not, whether he jumped off or not. Okay, because he's talking something which is not making any sense. Okay, then option C is neologism. Again we have discussed neologism. Neologism is when person uses a new word whose derivation we cannot understand. Now again, there is no such, no word, whose derivation you cannot understand. So it is not A, it is not C. Now let's talk about option B and D. Option B, flight of ideas, we have discussed. It is when the speed is increased. Okay, now again in the question they have not mentioned anything about the speed, and if they have not mentioned in the written question, I cannot tell about the speed. Okay, and loosening of association, we have discussed it under form. So please understand, both in flight of ideas and loosening of association, the first important difference is the speed. Speed is increased, here it is normal, but that is not mentioned. In both of them patient will talk about certain things illogical which we may not be able to understand, like in this question. Then how to differentiate? Can we differentiate? Now please understand, we have discussed in flight of ideas there are certain, although the patient is talking illogical, but there is some connection by chance, or there is some clang association. If you see, patient says home is sweet, sweet in diabetes, diabetes, urine has smell, smell. So there is some chance association is there. So the answer is flight of ideas. And where it is seen? It is seen in mania. Very important. Okay. Next question. Which of the following differentiates pseudo hallucination from hallucination? Okay, now we are discussing differentiation between pseudo hallucination. Both of them are disorders of perception. As real as vivid as real, both of them are as vivid as real. They are false, but they appear as if they are real. Sensory organs are not involved. This is also correct. Sensory organs, we've discussed, sensory organs are not involved in them. In fact, sometimes deprivation of sensation may lead to hallucination. Like someone wearing patch after cataract surgery, they may develop some hallucination. So sensory organs are normally not involved. Okay, no sense organs are required. They are involuntary, yes. It is independent of the will of the patient, yes. We've discussed both of them, they are involuntary. They occur in the inner subjective space, yes. We have discussed this. Pseudo hallucination, they occur in the inner subjective space, while hallucination, we have discussed, they occur in the outer world or outer objective space. So that is the point of difference. So this correct answer is option D. Next is, which of the following, again it's a recently asked question in your exam, disorder of form. Sometimes such simple questions may come. Okay, now thought insertion. So thought insertion is a disorder of possession of thought. Okay, under the thought alienation we have discussed thought insertion, withdrawal and broadcast. Delusion we have discussed, it's a disorder of content. Flight of ideas we have discussed, it's a disorder of flow or stream, and underflow it is disorder of increased speed. Okay, yes, correct answer is option C. Derailment, it is a formal thought disorder. Next is a 40-year-old male is suspicious that people are talking about him and spying on him, despite being trying to be convinced by the family members that no such thing is happening. So he is believing something which is actually not there. Which of the following statement is true? Now it is, which of the following is true? Okay, it is delusion of persecution. Is it delusion of persecution? Delusion of persecution when the person says, believe that someone is trying to harm him or kill him. Here he's saying they're talking about me or they're spying. So it is in fact delusion of reference. It is delusion of reference. So this is false. Is it a hallucination? No, it's a belief. It is not hallucination. Is it seen in anxiety disorder? No, it's a delusion. It's a delusion which is seen in psychotic disorder. So the correct answer is, it is a disorder of thought. In fact, it is a delusion which is described under content. Okay. And next is a 20-year-old male presents with laughing 1 minute and crying the next without any clear stimulus. So person is showing changes in his affect. Which of the following describes? Is it incongruent affect? Incongruent means when it is not in sync with the feeling or emotion. No, it is not incongruent. Okay. Is it elation? Elation is when the patient mood is excessively happy. Is it flat affect? In flat affect, basically there is no changes in emotion, even with stimulus. Here the patient is showing changes even without any clear stimulus. So this is labile affect. Yes, correct answer is C. It is labile affect, which may be seen in mania and organic mental disorders, right? So these were some important questions, and this was the topic of basics of psychiatry. Thank you.